Hello, good morning, everyone. I am Geeta, founder and CEO of Niramai. Thanks for joining us early morning of a weekend. Okay, good morning once again. We are here to hear to experts today from different segments of oncology and cancer. And I would say, I don't know whether you should say celebrate or come together on this World Cancer Day seminar. Of course, World Cancer Day was yesterday, and we are doing it today so that we can have more number of you join us. This year, as you may be aware, the theme of World Cancer Day is Close the Care Gap, try to make cancer care possible to everyone, irrespective of the economic status, social status, geography, all of this. And this day, I understand, is usually celebrated to celebrate the success of cancer survivors, how they have fought the disease and so on, and also create awareness in the whole community so that we are ready to fight. I think John Diamond once said, cancer is just a word, not a sentence, not a death sentence, right? Because it is possible to win over cancer as long as we are able to detect it early enough. The survival rates can be really, really high. So as a part of the cancer awareness creation efforts that Niramai has been doing for the last 5 to 6 years, we want to create a forum where we can discuss about risk factors, signs, symptoms of different types of cancers, figure out how one can detect it early. Is it possible to create a screening program where normal people or normal looking people can be screened to detect if there are any abnormalities, and then diagnose treatment and create a supportive care. So today we're going to hear about all of these for different types of cancers. But there are so many types of cancers. How do we choose, right? If you look at the statistics today, almost 20 million people are getting detected with cancer every year. You look at the Indian statistics, so almost 20% of all the cancers is just in India. It's crazy. How can we reduce this by making our lifestyle better? How do we fight it and survive, increase the mortality, increase the survival rate? And that is possible with early detection. Understanding what are the symptoms and what are the risk factors? How do we improve our lifestyle so that we kind of try to prevent it if possible? So by looking at the statistics, you will see that the top 3 cancers are breast, lip, oral, and so on, that is head and neck, and cervix. So we decided that we will focus today on these 3 main cancers and have experts from these areas come in and give us the knowledge. So Dr. Somsekhar sir is going to talk about breast cancer, Dr. Vishal Rao on head and neck cancer, and Dr. Sundari ma'am on cervical cancer. Before that, we would love to have a very well-known oncologist. Of course, all of these are well-known, very, very well-known oncologists. Dr. C. Ramachandra sir, the director of Kidwai Memorial, to give us a keynote. Before passing on, I just want to share a few things about Niramai and what we have been up to in the last 5.5 years, just 2 to 3 minutes. Focus of Niramai has been trying to address the challenges of breast cancer. Breast cancer is the top cancer in 159 countries and the second cancer in 23 other countries. So on this World Cancer Day, Nirama is also releasing several other activities and initiatives and care initiatives, particularly to fight breast cancer. As many of you may be aware, Nirama has come up with this new method of detecting breast cancer called thermalytics, which is now screen more than 45,000 to 50,000 women, and it can detect much before a lump is felt, and it is completely radiation-free cancer, radiation-free screening test, sorry. And it's a completely privacy-aware test where nobody sees or touches the person. It's now installed in 100+ hospitals in multiple cities. We've also released home health care, that is private screening at home. All you need to do is come to our website and book. We've also tried kiosks in different malls. Now we have in Vega City Mall, and people can go in and get instant reporting just as a risk. As a community outreach program, we have done several free screening camps, and continuously every day we do at least 3 free screening camps in 3 Bangalore referral hospital, government hospitals, and many other places in Bombay and Delhi as well. But if any of you want to send people who cannot afford to do this screening to any of the BBMP hospitals in Bangalore, for example, please get in touch. We will announce this, we'll provide the schedule, and they can actually avail this service. We also work with Karnataka Cancer Society to provide this service free of cost to many, many rural and urban poor. We have released a free online breast health assessment service, which is also validated, published, with the results are published, peer reviewed, and so on. And we have given a coupon code called Cancer Day. You just have to enter the coupon code to get access to this free service on HRA, that is healthriskassessment.niramai.com. I would really urge all of you to avail this. And next week, we are going to make this not just for breast health or breast cancer, but we will be expanding it to multiple other cancers. Stay tuned. The same breast health assessment, risk assessment service is available on WhatsApp as well. In fact, this is a WhatsApp number 94834344444, which can be used as a breast health helpline. Again, free. Any question on breast health can be sent on this, and experts will answer that. This is a simple free WhatsApp number. This week, we are celebrating World Cancer Day to create more and more awareness. And so we have many quizzes going on, quiz questions going on, mainly in Instagram. And please participate and learn more about cancer. And last but not the least, we conduct monthly awareness webinars and talks from experts about cancer, about women health particularly. And please come to our YouTube to actually take this, view these expert comments and talks. And now I'm very, very happy to welcome again all the speakers and all of you to this World Cancer Day Awareness Program, where we have experts, expert oncologists, expert gynecologists, who will share their knowledge in a very simple terms so that all of us can understand how we can all come together to fight it. Let's know it. Fight it. So with this, I would like to introduce Dr. C. Ramachandra sir, who is very, very well known, director of Kidwai Center, which is a regional cancer center for Bangalore. He's very well known, but let me briefly give his little bit of background information so that all of us can benefit from it. Dr. C. Ramachandra sir acquired his basic degree in MBBS from Bellary Medical College, and then post-graduation from Bangalore Medical College in 1984. In fact, he was a gold medalist for securing highest marks. He has underwent many, many training courses to enhance the personal skills and knowledge in oncology related topics, not just in India, but several countries. His professional experience is very well known. And he has developed a strong commitment in cancer control activities. He's leading several community oncology initiatives in Kidwai Memorial Institute of Oncology. Of course, he's also known for his administrative capabilities. It's not easy to run an institution as such, especially government funded. So he's established this with advanced molecular centers, bone marrow transplant unit, PET scan, all of these beautiful facilities available at very simple, affordable manner for many, many people. Dr. Ramachandra sir has many scientific publications, both in national and international journals, and he has been invited as a distinguished speaker and given several keynote addresses. He's also a life member of national and international professional organizations. He's won many, many awards as well. Dr. Sri Ramachandra sir has been awarded the prestigious Karnataka Nada Chetana by Government of Karnataka Award of Excellence during the Bangalore Health Festival, Nada Prabhu Kempegowda Award, and he's also won the University Gold Medal for securing the first rank in MS General Surgery. It's a real pleasure to have you, sir, to address this gathering with your, advice and guidance of how we can know it to fight it. I request you to kindly share. Thank you, sir.
Thank you very much. I thank the Niramai Foundation for inviting me as a chief guest today. Actually, in fact, I had another meeting, I had to cancel and postpone that to the next hour. So on the day of, World Cancer Day was celebrated yesterday, of course. The whole month is being celebrated as World Cancer Day. And one slogan is that together we'll fight cancer. That is my slogan for this. And the slogan for the year from the WHO is close the care gap. It means narrow down the care given to the cancer patients is the slogan. With this, there are a lot of my dear colleagues in this team. The due respect to everyone, please excuse me after this, 15 minutes. I have to go for one more function. I would like to tell you about the cancer. The ICMR, that is NCPDS, was established in, of course, the 1981. The cancer registry being established. Recently done study shows that in 20 and 25, there is 11.5% increase in cancer rate, all cancers, both women, men, and children's cancer. And the alarming sign is the increase in breast cancer. Another important thing is the most alarming sign is the increasing breast cancer among the young women. And I would call them as young children. In fact, recently, last 2 years back, I operated on a girl who is 19-year-old. I had to operate on her for bilateral breast cancer. It was very unfortunate to see the young kids are getting affected with breast cancer. Cancer itself, the world, is so fearful, and the whole family was shattered. So, likewise, I would like to brief mainly on, the important aspects like, increasing trends in the breast cancer, decreasing trends in the cervical cancer, the tobacco-related cancers, and of course, briefly, I would like to tell you about the alternative therapies in oncology. So coming to the breast cancer is being probably 30 years back. I don't know how many people have graduated 30 years back in this group. So it was about approximately the 23 or 24 per lakh population, screen population. Today in Bangalore, it is 34 to 35 per lakh. It means it is steeply increasing. And the worst alarming sign is increasing the breast cancer among the younger women. That is a cause for worry. And this is the learning age and earning age, where this is a time where people getting affected, the whole family comes to the road. Many times the bread earners are being affected. There are many reasons for the increase in the breast cancer. The most important, the cause for breast cancer is increase in the high level of estrogen levels. So this happens in many circumstances here. Most important thing is the lifestyle. These days, the lifestyle is the main cause. And the age of menarche is decreased in the past. If we compare to 25, 30 years back, today it's come to 10 to 11 years of age of menarche. And the age of menopause also is increased. Today, the age of marriage and the first child birth is approximately around 30 years or maybe after 30 years. And when they have children after 30 or 35 years, and imagine a girl who attains menarche at 10, 11 years and 35 years, 25 years, there is a high surge of estrogen levels in the body. This is the main cause for the development of breast cancer. Added to this, there are many other factors. The most important worry for the future of India is obesity. If you see the censuses, nearly about 20% of the children are obese today. Can you believe in a country like India, 20% of children are obese? And today, among the adults also, obesity is increasing day by day. One more other thing I would like to stress upon is the diet. Especially in a country like India, especially South India, we end up consuming more of calories. If you see a Chinese eating, there are 6 cups in a plate. You will have 5 cups of vegetables and probably some protein. Whereas in India, we eat half plate of rice and 1 small cup of vegetables. That is really troublesome. And people should tend to consume more of vegetables, fruits, and consumption of red meat is increasing, especially the fast foods. The supply of fast food, children have easy access to get it. And there is nothing wrong in eating white meat, like chicken, fish, and all, for people who are eating non-vegetarians. Whereas consumption of red meat is really alarming. So we should curb the consumption of red meat. This is also a cause for the obesity, is also important cause for colorectal cancers. So obesity is a human enemy. Probably 40 years back, no one was heard of bariatric surgery in India. Today, bariatric surgery is very much common in every hospital. So there are many other reasons like this, environmental factors, genetic factors. Genetic factor plays only about probably 10 to 12% or 15%. So majority of them are, sporadic cancers. The lifestyle is the main important factor. Added to this, one important factor where nowhere mentioned is stress. Everywhere there is a stress. A small kid carrying a big bag has a stress. A person who is going to job has got a stress. Person who settled down has got a stress. Everybody is going through stress factor. And another important thing is lack of exercise. These days, when we were children, we used to walk 4 to 5 kilometers to school and colleges. When we used to cycle also. Today, we very rarely see children. Even our own children, the moment they come out of the house, they want a car. The moment they come out of the school and colleges, they need a car. And this is the main cause for, obesity also. So briefly, I would like to tell about cervical cancer. Another good news is cervical cancer is decreasing in incidence in India. Probably if you see in late 80s and early 90s, it used to be 28 to 29 per lakh of screen population. Today, in Bangalore, it's about approximately 14, 15. With the introduction of vaccine and the hygienic and other measures improved, probably in another 5 years, it should come down to less than 10. Or day will come, probably will eradicate, will be in par with any of the Western countries after probably a decade or so. So this is mainly the reason being, in the past, if you see about 30, 40 years back or early when we got independent, those are the days where the younger kids, the girls were getting married at the age of 14, 15, 16, or immediately 2-3 years after menarche. So this is a very tender age, growing age. This was the major factor. In addition to that, hygiene. There were no sanitary napkins in rural areas, not heard of. Today you go to any village, everyone knows about sanitary napkins. There is a wide usage. It's a good news. Probably the country is progressing is one of the sign where the hygiene is being improved everywhere, including the rural areas. And another important factor is multiple factors. See, these days, people are aware of the barrier protection, and they know how to take care these days. So these are the improvements. Probably this is the reason the cervical cancer has decreased. In addition to that, the 2008, the cervical vaccine was introduced. 2 companies, major companies introduced. In fact, yesterday, Honorable Chief Minister and Honorable the Health Minister have inaugurated the the Cancer Day. In that, one of the assurances was to implement the vaccination for children between 9 and 15 years of age. They need about 2 doses with a gap of 6 months. and probably in future it will be taken up. This year, though everything is gone with the COVID, the country and the state has a lot of financial crisis. Probably next year onwards, we should plan to implement the cervical vaccine. And this will cover mainly the 16 and 18, of course, bivalent vaccine. And there are many variants in this bivalent, quadrivalent, univalent and all. And if we can implement the cheaper version, that is cover mainly the 16 and 18, the types of HPV, human papilloma virus, that should be good enough. I know we can nearly give about 85 to 90% protection for the cervical cancer. So coming to the tobacco related cancers, tobacco is being abused. I would say it's been overused in a country like India, Pakistan, and probably the Bangladesh, where the consumption of chewable tobacco is not in vogue in other countries. This part of the Asia, where they involve more in the production of this chewable tobacco and consumption of chewable tobacco, also in addition to the smoking tobacco. If see 70% of the lung cancers are because of tobacco, either chewable or smoking tobacco. So this way, if you see, tobacco is a harmful ingredient for every cancer. There is some connection between tobacco and cancer everywhere. Nearly approximately 25 to 30% of all cancers, if you see carefully, are because of tobacco. So I think we should put our step to prevent the consumption of tobacco. And in fact, recently, about 2.5 years back, the Honorable previous Chief Secretary, Vijay Bhaskar sir, actually set up a committee how to ban the chewable tobacco. When I'd gone through, there are a lot of legislations from Supreme Court. There are a lot of orders from the government of India, government of Karnataka. Unfortunately, nothing is being implemented. Today, the permission is there only for the areca nut production, whereas the tobacco containing sachets or tobacco containing chewable the sachets are not being permitted. It means to say most of these are produced illegally. And do you know what? It is worth some thousands of crores, and they don't pay any tax to the government. This way, the government also is at loss. The human life also is in trouble. So I think we all should put our first step to curb the consumption of tobacco. This is increasing among the children also because of easy availability, and it's cheaper, quite cheaper compared to all other drugs. And of course, narcotics, I don't have to tell you about the drugs. It is going in a very big way. Probably after Punjab, Bangalore, Hyderabad, Mumbai, these are the major cities where the consumption of drugs are being really high, going up day by day. I think we should protect our children, the future of the country, from consuming the narcotic drugs. Ladies and gentlemen, I would like to talk few words about the alternative therapy. And we all know that India is rich in Ayurveda, but unfortunately, we don't have a level 1 evidence in Ayurveda. So I cannot advise the consumption of, the usage of Ayurveda for cancer therapy because there is no level 1 evidence, number one. Number two, it is available plenty, the rich resource, no doubt, but there is no chemical structure. There is no proven data about the Ayurvedic therapy. It means to say it should have gone through like any other allopathic medicine from phase 1 till the end, the multiple phases, including, start from the animals and the advanced diseases. So like that. So many times, the consumption of this Ayurveda is being abused. In addition to Ayurveda, see, we also, many people, in fact, 1/3 of the patients, cancer patients anywhere in the country also use the other alternative therapies like homeopathy and many other therapies. So I would strongly suggest, unless there is a chemical structure is being found, unless there's a research happens, I won't advocate the Ayurvedic therapy, number one. It's not that I'm against Ayurveda. And the second thing is, when every therapy is exhausted, suppose a stage 4 cancer, where there is no hope, we are given radiotherapy, chemotherapy, surgery, everything is done. That is a stage where probably we can consider the alternative therapies in the end, when there is no other alternative, with the hope of at least increasing few days or probably increasing the quality of life in the end. But in the beginning of the stage, the cancer, probably there is no role for alternative therapies. Thank you very much.
Thank you very much for the insightful talk, sir. would you be able to take one question, sir, which is there on the,
Please.
I know you're busy, but maybe one question out here. What are the welfare facilities available for cancer patients? Maybe they are asking particularly in Kidwai, is there something that they can do? Sir?
I didn't get you, madam.
So they have, one of the persons have asked, what are the facilities available for cancer patients?
Oh, there are plenty. In fact, I didn't tell about the
Kidwai.
next the project for Karnataka is, the government of Karnataka is putting 10 mammogram machines all across the district headquarters wherever is not available, and 3 buses containing the ultrasound, X-ray, mammogram, blood test, colposcope, and a couch for taking pap smear and all will be sent beyond the Hubli and Taluka places all over the Karnataka one. Coming to Kidwai, we are no less than anybody now. We are actually lacking bone marrow transplant and PET scan. We are actually planning to put up the 2 PET scan machines very soon, and probably in another 1 or 2 months time. Bone marrow transplant is starting this month. In fact, we have really struggled to start. We have one of the best bone marrow transplant unit, 17-bedded bone marrow transplant unit. In fact, I want to give free of cost. Recently concluded government meeting, I have requested government to sanction 21 lakhs for the allogenic transplant, including 1 year suppression, the immunosuppression, and 7 lakhs for autologous transplant. My concern is the poor patient. Rich people can go and see Dr. Somsekhar. He can advise. So many times I'm bothered about the poor people of this country. So this way, the Kidwai has gone from with from a scratch to a very big level today. Probably the first government hospital to implement e-hospitalization. Probably next week onwards, we want to curb the use of paper. So initially it's a 23 acres campus. It's a very huge place. We have a patient load of last Monday. We had about 1,800 patients registered and about more than 200 patients unregistered. Imagine 2,000 patients plus more than 2,000 to 3,000 attenders. We had about 650 beds, and this month, probably another next week, we are going to increase another 150 beds. So slowly, I want to make it 1,000-bedded hospital. Number one, I want to segregate specialty block and the below poverty line block. Block, so that the people who can afford can get the treatment early. But I know the treatment remains same everywhere. And in addition, see, you name anything. Probably we were when we were student, we used to learn in ordinary hotel. Ordinary OTs. So in the sense, the modular OTs are not there. Today we have 12 modular OTs and 1 interventional OT and 1 operation theater for all scopies, including bronchoscopy, endoscopy, colonoscopy, everything for that matter. And that way, we have 2 CT scans, 1 MRI, 2 PET scans we are going to get. And there is nothing like it's not available here. But the only thing is where 500 people can be treated, 2,000 people will land up. So in this connection, I have requested the government has agreed to put up the peripheral cancer centers. The one has already started in Tumkur, and 1 center probably in another by March or April is going to start in Shimoga. And I want to set up a big center in Mysore and Hubli. And that is also the proposal is being submitted. Yesterday, I did speak to Health Minister and Honorable Chief Minister. He agreed to consider this in the next coming budget. So the whole idea is, cancer treatment, doesn't happen in one day. Many people should understand, just because, they come to Kidwai from all the way and from a far off place, you cannot give cancer treatment in 1 day, 2 days, or 3 days. There is a way of, evaluating. Cancer is a disease where you have to first diagnose the cell type and diagnose the type of cancer, evaluate, stage it, then plan it. So it needs radiotherapy, chemotherapy, and surgery, immunotherapy, anything for that matter. It takes approximately about 4 to 5 days to a week. If you take a core biopsy anywhere, it needs about 4 or 5 days to a week. So people should understand this. Just because they land up here, suddenly, you can't give a paracetamol and send them home. Thank you.
Thank you very much, sir. It was really, really an honor to have you. We now have the next, thanks a lot for the time, sir. We have the next speaker, Dr. Somsekhar, sir. I request our clinical research scientist, Dr. Lakshmi, to introduce Dr. Somsekhar, sir. And
Thank you, Dr. Geeta. Once again, thank you, Ramachandra sir, for delivering the very concise lecture and setting the context for today's webinar. As mentioned by sir, breast cancer is the most commonly diagnosed cancer in India, which is why our first topic for the day is breast cancer. We have with us Dr. Somashekar SP, who is the Chairman and Head, Department of Surgical Oncology, Manipal Hospitals, Bengaluru. An ace in academics and a gold medalist, he's been a breast cancer fellow at the University of Pittsburgh Medical Center and is also a member of the International Gynecological Cancer Society. He's the recipient of the prestigious Dr. D.D. Patil Gold Medal in Oncosurgery, the Millennium Gold Medal Award, and many more. He has various national and international publications to his name and has also contributed as an author and editor to many textbooks, including the Operative Atlases on Oncosurgery and Breast Surgery, Gynecological Oncology, and Robotic Surgery. Over to you, sir.
Thank you very much.
Sir.
Yeah.
Thank
We
you,
have to
sir.
go for another session. Thank you. Best
Thank
of
you.
luck.
Thank you for giving your time,
Bye.
sir. Thank
Bye
you.
bye.
Nice
Thank you,
seeing
sir.
you. Thank you.
Thank you, sir.
Can you make me co-host or something? I am not able to share my screen because it says permission is required from the host to share the presentation.
Yes, sir.
Yeah, if you just next to my name, click.
Yeah, you can share now, sir.
Yeah, thank you. Thank you very much. Thank you for inviting me, and especially on World Cancer Day and the preceding day after that, and this whole week and month. Thank you very much, Geeta and your whole team for taking such a beautiful endeavor of benefiting such a large community and doing so much of service. You and your company has been doing a fantastic work, trying to bring the best technology in the world down to the people at second level, third level city. I truly say Indian solution for Indian problem is something which you worked. Try to control the breast cancer and bring it down to all strata of people. Hats off to you and your company for fantastic work which you've been doing for a long time. I wish more and more people utilize this, and it's honor and pleasure to be part of such journey with you and your company.
Thank you so much for your kind words.
Thank you. So I bring warm regards from Association of Breast Surgeons of India as its national president, and also from Manipal Comprehensive as a professor and chairman. So we have so many of these ribbons: pink ribbon, then white ribbon, then we have teal color for cervical cancer. Why do we have this? Because people have short memory. We all speak about what should be done today, and today you forget. Tomorrow you go out, have a nice pizza, burger, popcorn, watch a nice multiplex movie, put on sedentary lifestyle, and don't do any cancer screening once a year. Screening is not done, and once a year pap smear HPV not done. That's why World Health Organization and UNICEF has put a ribbon and a specific day for each cancer, and February 4th for all cancer. So people at least are aware what's going to happen on this day. And we know for breast cancer, it is a pink ribbon. Now, if you see that World Health Organization has a theme for every year. Now, this year, the theme is Close the Cancer Gap. In India, we not only come late, we not only have an awareness and education about cancer, we wait for symptoms and problems to come. So because we wait for symptom to cancer to come or a lump to come, we are very late. So not only there is lack of awareness, lack of education, no screening available, even after you diagnose a cancer, your doctor nearby your home, public health hospital or a district hospital or any hospital, government hospital, private, anywhere in Karnataka, you diagnose a cancer, from then coming back to a specialist and completing the treatment again is delay. So the theme this year is Close the Cancer Gap. There are a lot of gaps at all the levels. Education, screening, accessibility. So close the cancer gap, end the cancer as we know it everywhere. So the campaign is, there are a lot of challenges and problem, and reduce all this and help. So this is the theme. So we have to all join hands. Remember, now this is not an era of maximum tolerable treatment. In old time, we used to say, you just bombard the patient with all maximum surgery, removing the breast, giving all chemo, radiation, toxic. No. Now we know it is not maximum tolerable treatment, but it is a minimum effective treatment adequate to cure a patient, still not compromising the oncological outcome, maintaining the cosmesis quality of life. This is an era of organ preservation protocol. Breast cancer, we no longer remove the breast. Woman retains the breast cosmesis, her own dignity and social factors. Voice box cancer, we don't remove voice box. Multimodality treatment, organ preserved. Rectal cancer, we don't do a permanent bag or removing the sphincter area unless it is involved. It is a preservation. So this is an era of multimodality treatment. Now, this is very important to understand. We don't do unwanted too high treatment, which is harmful, and not too conservative. So this line is very important. So what are the aims? We want to know what is the current status of breast healthcare in India. What are the facts and realities? Lot of people have a myth. You know, they say that half-baked knowledge, bad knowledge is more dangerous than not having a knowledge. In India, woman thinks every lump is cancer. She decides, okay, I'm done. Now I'm going to die. I'm not going to go to doctor. He will remove my breast. Remember, 99% of the lump in the breast a woman has are not cancer. That is where, you know, the technology which Geeta's company has brought, which is based on that artificial intelligence. Use that. Know which lump needs to go to doctor, which lump don't have to go to doctor. Remember, don't avoid getting checked with the fear of cancer. Look at the positive side. Get a proper check. 99% it is not cancer. Enjoy your full life. You know, big headache on the head is gone. You relax, you enjoy, go be positive. So the advantage of early checkup is we can prove you don't have cancer. Go back to your society, family, enjoy your life. So it is very, very important. Second, everybody cannot afford mammogram. India cannot have mammography machine, mammography things. So there are more than different technology which we need to Indianize them. Second, we always say that, okay, everybody with breast cancer means loss of breast. No. These are the points which Ramchandra enumerated: lifestyle change, lack of awareness, screening programs, talks like this organized, and then, you know, resource constraint. Everybody cannot go to pay and then have a big mammogram, and then you need an interpretation. Not possible. So in India, you cannot do a screening, mass screening. So these things are very important to understand. Majority, how does Indian breast cancer differ from outside? Indian breast cancer, majority are higher grade, fast multiplying. Average tumor size in India, unfortunately, is 4 to 5 centimeter. It is coming on to 3.2. Overall 5-year survival is very poor in India. Young woman in India, 1 decade it is early. See, look at 2008 to 2012. There is a jump in 17,000 deaths because of cancer. When I came to Bangalore from US, the incidence was 17.3 per 100,000. Now it is 32 per 100,000 in Bangalore. Alarming pace it is increasing. In abroad, number of women with breast cancer is high, but they don't die. 75% to 90% of them live. But in India, the mortality is 50%. 1 in 2 women die because they come late, there is a gap, they get the treatment late. This is very sad. We are not the largest contributor of incidence, but we are contributing maximum deaths, which is very, very, very sad. So in India, less than 5% of the women undergo screening. Population screening is almost non-existent. Huge cost to mammogram. And dense breast young woman, mammography is not very sensitive for us. So these are all the factors, you know, which a woman has, taking a nulliparity, not breastfeeding properly, sedentary life, obesity, which needs to be avoided. What are the myths? Oh, in my family, there is no breast cancer, so I will not get. Remember, all breast cancers are not familial hereditary. Less than 10-15% only. 85% you could be the first person. So don't ignore it. It's very, very important to understand. They say that, okay, if my mother has, do I always have it? As long as you don't have BRCA1/BRCA2 genetic, your risk is 1.2. One of our close relative has breast cancer. Do I have it? If they are blood relative less than 40, yes, you have a higher risk. If there is a family history of gene syndrome where ovary cancer happened, then you can look at it. But in India, there is a tsunami of breast cancer. All of you, all the doctors know, and Geeta knows, what we currently report, okay, we have every year 1,54,000, tip of iceberg. 10 times more is available in India outside because women don't get it. Look at, you know, in India, we have 32 per 1,000, of cases, but that is the number one cancer and number one death that is happening. So this is most important cancer. But what is worrying trend in India is, in India, it is 1 decade, 10 years early. Young woman, productive life, dense breast, mammography not sensitive to INT5. And you are young and you're not even started your life. You finished your graduation, just got into job, you're opening, your books are out, you're spreading and you're leaving, breast cancer hits you. So you must be very careful. Dense breast, young woman, 30 year, mammography not sensitive in India, very high chance of mortality. Why you should undergo a proper checkup? If you come in first cancer, there is 97% you live full 100 years of your life. The moment you come, when you have a lump in stage 2, look at the way the cancer survival drops down to 90%. Third stage, less than 70, fourth stage, rarely curable. That is why it is very important in India for us to understand. Like people like all the NGOs, association, Geeta's company, Association of Breast Surgeons, we formed a team. Voice of breast cancer. So that is where you need to understand changes. What are the unfavorable statistics? Indian woman, young breast cancer. Percentage detected early, less than 10%. More or complicated. 5-year survival, only 50% because of late coming, not accessing more treatment. Annual incidence in India is climbing by 3 to 4% every year. Percentage of women screened less than 1%. And dense breast radiologists are not available in a country. That's why you need to use different type of modality. So, thermal screening mechanism, mass screening, breast self-examination, clinical breast examination once a year. If a woman every month, 5th day after her menstrual cycle, stand in front of the mirror, examines herself thoroughly, 18% you can add extra life to you. If you can go and meet a clinician and get it checked, 24% extra you can have. 5 points. Know what is normal in your breast. You know better than anybody. Feel what is abnormal, thickening of the skin, nipple going back, lump in the armpit. Look and feel. Any abnormality, please report to your doctor. And then have a screening done yourself. These pamphlets are all available everywhere. How to do sitting position, standing position. But I'll tell you what is most important to be done. Understand, breast is not what you see alone. It goes up to collarbone, goes up to the tummy, armpit, and to the central area, and axillary tail is commonly missed, and inframammary fold. So how to do this particular evaluation? Most of the even doctors don't know. Look at this photo I have put. Take the palm, join 3 finger, make a pad of 3 finger. Pad of these 3 finger. Flex it, palpate the breast, light, medium pressure, deep pressure. Cyst, lump. So, and another thing, don't be in a hurry. Look at this clock. What is the recommendation to check? 3 minutes per breast you have to check. Most of the time, even doctors spend less than 1.8 minutes. And thorough examination of the axillary doesn't happen. So please make sure you do this and use good screening tool. Everybody cannot afford mammogram. If you can do, you have an access, please do it. Or go back, Google and read about the artificial intelligence technology which Geeta has developed to identify which is abnormal, which is normal. Even you can read and you can utilize. It's available in Bangalore now, rural area also. They're going all over India. They launched a campaign. You can go back and utilize this particular area. If you are a young woman, try to add ultrasound. Now there are some myths with the people. Oh, I get cancer by screening only. Wrong. It is very painful. No. If I press my breast causes cancer. No. All lumps are cancer, they'll remove a breast. Wrong. 99% no. So remember these myths, you remove it off. Second, if I go, I'll get cancer in the screening. No. When you screen 1,000 women, 3 only will have cancer. 997 women are out of their mental agony and misery. Those 3 women you identify early are cured and retain the breast. Imagine what is the benefit you have. We have analyzed all over India, more so in Karnataka, what is the incidence. Look, 2014 to 2018, because women are aware, we are coming, screening has moved to periphery, breast conservation rate has gone up to 60%, which is very, very good. Women are started coming in small tumor and it is helping us. If you notice any abnormality in a lump, we do 3 triple assessment, clinical checkup, radiological imaging and a biopsy. And if you have a nipple discharge, remember, red nipple discharge doesn't mean cancer. Water discharge is important. If you have a pain, we call mastalgia, rarely it is cancer. So painless lump of recent onset with thickening of the skin, nipple going back is harmful. Please report to your doctor. Rest all could be all these benign, non-cancerous thing. And we do something called triple assessment, which will give 95% chance for us to do. That is a gold standard to do. What is the advantage? A normal woman who don't do any breast self-examination, this is the size she does. Who does breast self-examination, this is the size. Who do screening every year, this is the size. It is common sense. If you come with this small, less than peanut, breast is retained. First stage, fever is very high. You may not need chemo or radiation. Second thing, there is so much advances. You don't get this lymphedema, elephant hands now no longer, because there is a technology called Sentinel. Now, you know, the current government concept is Indian solution for Indian problem, make in India solution. That is how Geeta's company has developed artificial intelligence validated in Indian woman. So similarly, we also developed an Indian probe in Bangalore with Indian Institute of Science and like-minded people, where we can't use expensive Western probes, which are lakhs and lakhs rupees. And then this is a small ICG, which is made and available in Coimbatore and also in Madurai, few hundred rupees. We give this blue-green medicine for the woman during the breast cancer surgery. And during surgery, this particular lymph node, which is fluorescing, like a glowworm is seen. And if you use this, you don't get complication. And this is a study we have done, and we have published in an international journal. Now we don't look abroad, we don't look east versus west. Now west looks to India for an answer for us. So these are the things available. Now new technology probes available, even non-palpable cancer. So these are called as role or occurrence. So in conclusion, remember this: what mind doesn't know, I cannot see. Rising incidence mortality is because we are all responsible. We are not educating people. We are not getting screening done for our own mother, wife, and then family, sisters. We don't notify the cancer, and we have to urgently change to improve. So that is why, we have to take a pledge on this breast cancer day. When there is a birthday of my mother, my sister, my wife, I will not gift a diamond necklace or a sari or take them for a movie or this. I will ask my question: did I get my mother, my sister, my wife's breast screening today? Gift a screening pack nearest. Go and get it done and save the life for 1 year. And then you can go and enjoy your birthday later. So it's very important to have this awareness, understand it. If you change yourself, your family, then society, then your mola, then the nation changes. So remember, there may be a lot of dark clouds, but always there is a beautiful silver lining in the knowledge and cure. Now breast cancer is fully curable disease. You retain the breast, achieve this knowledge and spread this knowledge on this, World Cancer Day. And please change yourself and the whole community. Thank you very much.
Thank you, sir. Thank you for the very interesting talk and addressing the myths and encouraging everyone out here to get ourselves screened. The more open we talk about this, the more conversations we have this, if each person can convince 5 more people to go get themselves screened, I think our screening rates will increase from the sad number that it is right today. So, and the fact that cancer is affecting younger women when we are least expecting it is quite alarming. We need to be aware that breast cancer can happen to any one of us. Thank you, sir. So we have a question here. They're asking, if it is affecting younger women, why does it happen to younger women? Yes. And I think that's one question that everybody wants to know. Why me? Yeah.
See, there are 2 reasons in India. The breast cancer is because of westernization. If you remember, in old time, we used to grow our own vegetables, manual laborers, and used to take a vegetables, cook same day and eat, no refrigeration, no high fat. Now, and then everybody used to have a child and a breastfeed. Now what has happened? Because of our westernization, we put on lot of weight, obese. Weekly vegetables brought, kept in fridge, all antioxidants gone. Sedentary lifestyle. Everybody delay their pregnancy beyond 30 years. Maximum have 1 child, rarely 2. And we don't breastfeed them. And we take hormone pills to delay the menstrual cycle. Or we have a lot of PCOD and infertility. So full westernization has happened. No physical activity, no fresh fruits, no fresh vegetables, sedentary life, delaying marriage and not breastfeeding the children. That is why we have taken bad parts from the Western world and we are taking all that. and no screening to add to that. That's one of the reason India, young woman, it is very common. And by and large, Indian population is very young population. So that's why we are 1 decade early compared to Western population, which is very sad.
Right. So, just to summarize, a lifestyle change will be a major factor that we can ourselves employ so that we can reduce the risk of breast cancer. Thank you, sir. So you did mention about screening. Is there any particular age that a woman needs to start screening?
Yeah. Now, number one, every woman after her menarche should do breast self-examination herself 5th day after her menstrual cycle. So the breast changes become normal. If there is a postmenopausal lady, she can identify a birthday of that month. Say your birthday is 15th of some month, so 15th you'll always remember. So that day you have to do. Now the screening should be started when you are 40 years if there is no high risk incidence in your family. 40 years, you should add screening in addition to breast self-examination. But if you have a hereditary breast cancer, like your mother had a breast cancer or there multiple history of breast cancer, ovarian cancer, then you start 3 to 4 years before the youngest in your family had. Usually then we recommend at the age of 37. Otherwise, after 40 years, you must do it. And, it should go lifelong preferably, but at least up to 70 years.
And the self-breast examination, when can any woman start doing
Any woman after her menarche should start integrating into her life 5 days after her menstrual cycle while taking bath in front of mirror and also examine, palpate and feel it.
Thank you, sir. If there are any more questions, you can leave on the chat. I had few questions I asked them. If there are any questions.
Yeah, it was a wonderful talk, sir, actually.
Thank you very much, Geeta.
So one of the questions that we get asked all the time is how often should people repeat the test, right? Of course, some countries have once a year. UK has once in 3 years. So, and I think the government says once in 5 years CBE for India. So what is your recommendation, especially?
It is directly dependent on the screening protocols available in a country, infrastructure facility available. Ideally, if there is no constraint, annual is recommended. But the sad part in most of the countries, even in their entire lifetime, woman doesn't get even one screening. And a huge country like our 1.4 billion population with about 50, crore of people who are there, it is very difficult for us to do. So the recommendation is from age 40 to 50, please at least to do once a year. If 3 consecutive year screening protocol comes normal, then you can move them to once in 3 years. So imagine a woman in India entire lifetime, not even once, at least once in 3 years changes. But it is recommended since in India, young women can get more. First 10 years of screening do every year. If you're lucky, you are being stable for 3 years, then you can move it once in 3 years.
Okay, that's very useful information. So because when we do the screening also, we find almost 97.8% of women are having the test for the first time.
First time, absolutely.
So it's a very interesting thing that after 3 years you can say, yeah.
Correct.
Other question we get asked many times is the cancer recurrence chances, right? So either in the same breast or contralateral breast, and sort of, what has been your experience in India particularly on that?
Remember, the recurrence is the stage which it to come. It's a common knowledge that if you come in stage 1, the recurrence is usually 3 to 4% only. The moment you come late, when the lump is more than 2 centimeters, then stage 2, you go to about 10% recurrence, stage 3, 15%, stage 4, no permanent cure. So coming early is very important. In addition to this, also the type of treatment you took and the genomic make of the breast cancer. Usually breast cancer come because of the estrogen hormone, which comes from ovaries and also from high obesity fat cells in the body. So if there is a estrogen positive sensitive breast cancer, they do much better. Their cure rate is much better than estrogen negative tumors. There is another marker called HER2/neu. So now we classify breast cancer based on genomic into luminal A, B, and other types. Triple negative has more chance of recurrence. HER2/neu, if you don't take the antibody therapy, has got more chance. So by and large stage, how early you take treatment, how effectively you complete the treatment. Many people do surgery, go off, I don't want anything more. Or they do surgery, take little chemo and go off, they don't take radiation if recommended. Or they don't take 5 years, 7 years of hormone. Completing the treatment is a good chance to beat the recurrence. Coming early at early stage, beat the recurrence. There are some non-modified factor, not in your hand, my hand, which I told you, the genomics make of the tumor, which is receptor and HER2/neu. So those things are there. So then we normally try to treat them optimally when we know there are high risk factors. But by and large, breast cancer now is highly curable. Even fourth stage breast cancer women routinely live 5 to 10 years with the current treatment.
And in India, we don't have genetic tests so widely available as well.
Unfortunately, yeah, and it's expensive.
Expensive.
People are not undergoing that yet.
Sure. Thank you.
So we have one more question.
Yeah.
A participant has asked, I breastfed all my 3 kids. Even then I got CA right breast. So is that a myth?
Because remember, there are more than one factor. Breastfeeding is not the only factor. So if you have breastfed, be lucky it came late to you probably. You might have come in little early stage and you will do better than other people. But you cannot say that only because again, family history, your physical activity, your body mass, weight, there are multifactorial causes. Only one is not the reason. It's not that you breastfeed. So if you breastfeed, then you knew it is little better than other people. So there are multifactorial causes and all of them needs to be done together.
Right. Thank you, sir. So one more question is, how expensive is genomic testing and which is the most affordable place to do?
Yeah, usually it costs roughly about 10 to 15,000 in India at this moment. It used to be 40 to 50. Now it is about 10 to 15,000 rupees. So still it is expensive for very low socioeconomic strata people. It takes about 2 to 3 weeks for the test to come. It used to be 50 to 60,000 few years before. Now it is roughly 10 to 15,000 rupees. In Bangalore, it is widely available.
Thank you, sir. Thank you so much, sir. Thank you so much for taking your time out there and convincing all of us, those who are especially not convinced, to go ahead and get a breast cancer.
I think there's one more question. It says from DPC, I think even from Karnataka government. Actually, I'm very happy to say that we are maxed. We are more than 100 people joining. It was an excellent, it shows what kind of information is being delivered. So lumps remained after lactation. That's what, that was just a comment put, but maybe you can talk about lumps and lactation.
See, remember, during lactation, 2 things happen. One is the milk cyst happen, galactose, so it's possible. Plus hormone imbalance causes lumpiness in the breast. But the problem during pregnancy is breast cancer gets masked. And breastfeeding and lactation time is a immunosuppressed complex. Usually cancers flare up. So you need to get a good ultrasound at that time. Mammography cannot identify. A good imaging is important, and breast cancer is difficult to identify because there are normal, natural, physiological lactation-induced changes in the breast, which would even prevent a good doctor to identify that. So that's why it is very important that if you have them, most of them could be harmless, milk cysts. If you do a good evaluation, examination, ultrasound, you can identify a hidden cancer, so there is no delay. Otherwise, 9 months later, you're going to come to your doctor and you come in an inflammatory advanced breast cancer. So don't neglect that. Tell your gynecologist, she will get a good ultrasound screening done, examination.
Thank you very much, sir. I think it was a super good session and a lot of knowledge, which is understandable by end users. So we really are privileged to have you.
Thank you very much. Bye.
Thank you, sir.
Over to you, Dr. Lakshmi.
Thank you, Geeta. So we have heard the story from a doctor. Now let us hear it from a cancer conqueror. I wouldn't say a survivor, but a cancer conqueror. I would also not call this the story from the other side because I believe the patient is very much part of the treatment plan. On that note, I welcome Ms. Megha Jagirdar, who's here to share her journey with us. From being a passionate school teacher to getting diagnosed at the age of 46, she has seen it all. We're very glad you could join us today here, ma'am. I request Dr. Tanveen to take it over from me.
Hello. Welcome, Mrs. Megha. Thank you for joining us today.
Yes, thank you.
So, Dr. Lakshmi, as for everyone, as she introduced, Mrs. Megha is a breast cancer survivor. So, Mrs. Megha, I would want to ask you, how did it happen? How old were you? And, were you self-aware? Like, how did you come to know that you have breast cancer?
Yes. Good morning. It was all about 10 years back, actually happened.
Okay.
That time, just in my left breast, small lump was there. So there was no pain and nothing, no weakness, nothing was there. but I found that small slump is there. So we used to stay in Mumbai that time, and my husband used to work in Jalgaon. So Saturday, Sunday he used to come. So I told him that some small lump is there. So he told, just don't worry, and whatever is there, go and ask to doctor. So immediately I went alone there, and I asked my doctor that like this it is there. So she told that you just do one mammography, and after that we will see. So in mammography, that report was not confirmed. So my gynecologist told me that you just go to that biopsy you do, and after biopsy we can see. So after my husband came one Saturday, Sunday, we went there, and biopsy done. That time it was confirmed that I have a cancer, breast cancer in my left breast. So after that, it was really shock to me. And my husband told that, no, don't worry. Just he took immediate action, and he called his uncle, who is doctor. And after that, we have taken appointment. It was all in February 2012, exactly 10 years back. And all this process was done. Then after that, within 15 days, we have took appointment, and in Belgaum Cancer Hospital, we have decided to do operation there. And we went there, and operation was done by that. There one Sandeep Madhvapati doctor is there. He has done the operation successfully, and everything normal. Means that he told that you came early, that's why it is no risk at all. Means you came early, that's very good, he told me. Then within 15 days, everything done. In February detected, and March 5th, 2012, I have been operated. Then after that, chemotherapy was there. All 6 months treatment was going on. 6 sessions of chemotherapy for every 15 days gap. And after last month, the radiation was there. So all treatment I have gone through that. Up to 6 months, I have taken that all treatment and everything. Then after that, now okay, it is. Now we have settled in a village now, actually.
How did you find out? Did you used to check yourself every day? Every month? Or...
Yes. At that time, actually, mobile was not that time. No, this much that it was not there in our hand, mobiles and all. In TV and in magazines, we used to read that all, everything. So self-checking was important. No, so that I usually did that self-checking. That's why I found that small lump is there. Something I have doubted that something is there my left breast. So I went to the doctor there to check up.
That's very, very self-aware of you, very intelligent.
Yes.
And as even Dr. Somashekhar mentioned, and Dr. Geeta keeps stressing on it, that most women report to the doctor at an advanced stage, because you were lucky, you went way early, and you're perfectly fine now. It's been 10 years. Yes. How much do you think that factor that you used to check yourself helped you?
That is very important. Early checking is only the first step that you have to take, because when you go to doctor early, then if first stage is there, we can cure, and medicines also will be that not this one strong one. No, after third, fourth stage, it is too much. This one, bahut irritate ho jata hai then. So first stage, that is always better, na. So early detection is very important.
Right. And did you know about breast cancer before? Like, I know you read about checking yourself in the magazines and everything, but what exactly is breast cancer? How bad it is?
Yeah, I didn't know exactly. I don't know anything that time, actually. And nowadays we are seeing in the YouTube and all that. At that time YouTube was not there, no. So I didn't know anything. But first first time I have gone through, and in my family also nobody has that cancer and all. So first time that I have gone through, and but whatever happened to me, that I have accepted, and I have moved on. That's all.
Sorry, I was on mute. And how is the support from your family's side? I understand you have 2 daughters. So how did they react? And how did your husband, how was
No.
the whole journey like personally?
Yeah, that is most important. Because of my husband and daughters, they have my confidence have boost up actually. Actually what happened in Belgaum, I have stayed in my uncle and auntie's house. They are also very supportive, and my daughters both were studying at that time. They were in different place, and my husband was working, he is in different place, but daily they used to call me up and boost up, and confidence made me, that my uncle, auntie, my brother, and all relatives, friends, everybody has helped me that time, really. And my daughters, they are only very confident. So looking at them, the confidence level has increased really.
That's very sweet to hear. And what kind of treatment did you get exactly? I understand you got surgery and then a chemo. What stage were you in when you got diagnosed?
Hello, repeat the question. I
Yes.
didn't.
What stage were you in, ma'am, when you got diagnosed?
Yeah, first stage only it was
First
actually.
stage. And how was the treatment? How was the personal experience with the whole surgery and chemo?
Yeah, surgery, it was at surgery time, no, there was nothing to miss, not to worry at all. But when taking chemotherapy, na, hello.
We can
Yes,
hear
yes.
you.
Yes,
Hello,
yes.
hello.
Yes, ma'am.
Yeah, during chemotherapy, no, that all side effects were there. No, that time I was little bit depressed actually. But after that, everybody has make it like jokingly that time na passed. Everybody was jokingly that told me that okay, it is you are looking so good, and after hair is removed, that time na chemotherapy time na every hair loss was there na. So everybody was jokingly tell me that you are looking so good. So everybody boost up me. So that period also, now afterwards, we have taken it jokingly. That's all.
That's a very positive attitude to have.
Yeah. Everybody have filled confidence in me that time.
Wonderful. And what is one thing which you wish that you knew before you started treatment? Like, not everyone prepares you. You're not prepared, you'll get breast cancer. You're not prepared, you'll get chemo and your hair will fall off. So what is that one thing which should have been told to you for being mentally prepared?
Mentally, we have to prepare for everything. I think nowadays, now whatever happens, that we have to accept it. That's all. Because nowadays the lifestyle is also has so much change, na? So anything can be happened. So whatever happens, we have to accept it, and we have to move on in life. That's all.
During the course of your treatment, surgery, chemo, radio, which phase do you think was most difficult, physically, emotionally, for your family? What was the most difficult and the biggest obstacle that you found?
Voice.
What was the biggest difficulty that you faced during your treatment part, from your chemo to your surgery to radio?
Chemotherapy was very much difficult actually. That time, that medication was also very strong, and while eating also, now I don't have to. Means taste, tongue taste was also gone because of that treatment and all. I was not eating properly that time actually. But my auntie was there now. She was giving me all time to time everything. So I am very much thankful to her actually.
That's great.
Hello.
All this while, I see that your family, is my audio better now?
Yeah,
I
now
see
it
that your family was very supportive. Your daughters were supportive, and your husband,
Yes,
even when he was away, he was very supportive. They
yes,
would
yes,
check
yes.
on you every day. How
Hello.
did you find the strength and the motivation to go through it, through the entire journey? I mean, it can get very
Yeah,
difficult. I've seen my relatives. So, how did you go through?
yeah. No, it is very difficult that time, but supportive family, friends is much necessary actually, because at that time, no, that is only needed. Only because of tablets and treatment, that is okay. But beside of that, that family support should also be there. So everybody has supported me in my family and my relatives. So thank for that, and thankful for everyone.
Right. And how is life now? 10 years, you have survived everything, you've gone through, and now it's 10 years you're sitting here talking to us, sharing your experience. How has your life changed? How have your thoughts about life changed after that experience?
Yeah, it was now actually Mumbai, that hustle bustle world was there, and now here in village, everybody, everything normal and everything that is pollution free area is here. So I'm enjoying this life now, retirement life actually.
That's wonderful. I think those are all the questions from my side. We're open to questions if anyone wants to ask anything from the audience.
I really, congratulate you, ma'am. You are really a fighter, and hats off. And it's really nice to see smiling face. You're an example saying that cancer is just a word and not a sentence. And I think you're really an inspiration to so many people, right?
Yes, thank you, ma'am.
Really, really thankful for sharing your experience.
Thank you, ma'am. Thank you, Tanvi, for
Ma'am,
taking.
before concluding, I want to tell some
Please,
5
please.
things.
Yes.
Before conclude, only 5 points I want to tell.
Please,
Just
please. Go ahead.
that is, early detection is first thing we have to do. Early detection. Whenever you have some doubt, go and ask the doctor. And second one is timely treatment. That is, immediately after detection, you go and take timely treatment. Don't delay. And third one is accept whatever you have come in my life, that I have to accept it and I have to move on. Third one then. Then fourth one is positive mind, that we have to make a positive mind, that confidence level we should not decrease. Then that fifth is take some exercises and proper diet. That's all. That I feel that these points everybody should inculcate in their life, so that whatever they face in their life, they can come from that. So
excellent points. Thank you.
Thank you so much, ma'am.
Thank you so much for sharing.
Thank you so much.
I've given the opportunity to share my experience. So thank you so much.
Thank you so much, ma'am. All the best.
Okay.
Thank you so much, ma'am. It was such a joy. It was an absolute joy to listen to you. And thank you, Dr. Tanveen, for taking us through that very honest conversation. We need more such people, more such conquerors talking to us, to not have that taboo. Okay, I shouldn't go for cancer screening today. What if I get cancer? I think if more women like Ms. Mika Jagirdar goes out and talks to people, we will also, this is the fight together. Thank you so much. I hope others here get the message strongly that you need to prioritize your health over every other thing. Yes, men and women out there, please get yourself screened routinely for common cancers. We will take this opportunity to show you how to examine yourself every month for breast abnormalities. We'll play a short video.
After
Dr.
this,
Tanveen,
will be Dr. Vishal Rao's head and neck cancer.
Yes. Dr. Tanveen, let me know when you're
Thank you so much, Dr. Megha ma'am. Okay, excellent. So for the next speaker, should I share another video?
Sure, Dr. Geeta. So as mentioned by Dr. Somashekar sir, please remember that along with the monthly self-breast examination, an annual breast screening by Niramai thermolytics or mammography or ultrasound is necessary. We now have a video of a patient experience. Please have a look at it.
Recently, I lost a family member to breast cancer, and I know that as a woman, breast cancer is something that I have to keep checking myself for. Unfortunately, there's no way that is safe, reliable, and easy to find out about malignancy. While doing a lot of research and discussing this issue with my friends, one of them suggested the Niramai technology to me. Having heard about it, I went to get a checkup done. I was quite skeptical before I went for the test. It took me by surprise because the machines didn't touch me. It was all happening from far away. जैसे eye test होते हैं ना, दूर से बिल्कुल वैसा.
Yeah, that is how simple Niramai test is. So maybe we take this opportunity to ask, Mrs. Megha Jagirdar, ma'am, how was your experience of taking Niramai test, ma'am, actually? You can unmute yourself.
Okay. Yeah. I have done that first time last 3 months back, I think so. It was actually very nice, ma'am. Because the doctor told me every year I have to do mammography and I have to show the report. So mammography is little bit tension wala kaam hai. Matlab, we have to press the breast and all, na? And that machine also touches, and that is little bit painful actually. But this screening test, na, that is very nice actually. I have done first time that one. That experience was really good.
Okay, very nice, very nice. Thank you so much for sharing.
Yes, thank you, ma'am.
We are waiting for the next speaker who will join in 5 minutes. So meanwhile, thank you so much, ma'am. If you want to share anything else, with the audience, ma'am, happy to.
No, that only that every time I will tell that whatever you comes in life, that accept and move on. That's all.
Okay. Thank you so much. And again, congratulations for fighting. And
yes, ma'am. Thank you.
Really an inspiration. Thank you so much, ma'am.
Thank you, ma'am.
So while we wait for Dr. Vishal sir to join, so I would like to share a few more information staying on the breast cancer theme about thermolytics itself, right? What exactly it is, why are people doctors suggesting that we should take it, as Mrs. Megha ma'am also mentioned, right? It's a very, very simple test, no compression, nothing. So because today, mammography does not work on younger women, and women have, having what are called as dense breasts. And of course, there's also this question of whether rural women and urban poor can actually afford it. And so in that context, right, what Niramai test does is it can actually detect much before hand examination can detect. It's a completely non-contact, non-invasive test where nobody sees or touches the person, and where the lady is inside a screening booth and the technician is also outside. There's absolutely no radiation. It works for women of all age groups. It can be actually, we were unfortunate to actually find a 17-year-old who is cancerous with this test. And of course, men also can get cancer. It's only 1 in 1,000, but men also can get screened with this. We just use a thermal sensor, measure the temperature variations on the chest, and we've developed this AI algorithm that Dr. Somashekar sir also mentioned, which can analyze and give a report immediately to say whether there is a likely abnormality, and it is what's the probability that it is malignant, and so on. Of course, if you want, you can actually have a very detailed report as well. When we go to a hospital, you'll actually get a 3-page report. It's much more affordable because it's portable. We are able to conduct screening camps and so on. In fact, with working with National Health Mission Karnataka, we are running a program in Gulbarga. More than 2,500 women screened just in 4 months' time, right? It is possible because we were able to take this portable solution. It's like 2-liter water bottle and take it out to do screening even in the villages. And this is technique which we call as thermalytics is actually patented. It's made in India for the world, and 25 granted patents just on this. That shows that it's a very unique idea, making a difference in the world, as again, Dr. Somshekhar was mentioning. And like I said, we just measure the temperature variations on the chest. You get an image like this. You can't, it's not like a real image. It's really an image where it shows the different temperatures. So for example, white is highest temperature, red is lower temperature, and things like that. And using these AI algorithms, we are able to analyze this temperature. 4 lakh temperature points per person is measured. We analyze that to actually generate a report automatically. And so this is something that so far has made a difference to almost 50,000 women, actually more than 45,000. And we've deployed in 100 plus hospitals in 17 cities today. And we've conducted thousands of outreach programs. Like I mentioned earlier, we conduct free screenings every day, at least 3 free camps every day. We conduct for urban poor. And right now it is running really regularly in the BBMP hospitals. Any BBMP, that is a Bangalore referral hospital nearby, you can please send anyone who who you think should get screened, which is every lady about 20 years. Or of course, there are multiple hospitals like Apollo Clinics, HCG Hospital in Mumbai. We have Health Spring, and of course, Apollo Clinic everywhere, Delhi, everywhere, right? Hyderabad, Chennai. So all of these places we have. You can come to our niramai.com website, just say book appointment, and our team will tell you which is the closest center to to get it. If you feel you don't want to go to a hospital for a test, but you will wait at home, you will want to get this test done at home, you can do so with private screening that we provide. This is called home screening. You can just say, I want to check if people can do screening. And it's just about 20 minutes. Sometimes it may take up to half an hour. It depends on the setup that is available at your home. And we will be able to, do the screening. And then radiologist certificate, radiologist signed reports will be given, right? So this is this is what it allows us to do. Dr. Lakshmi, would you like to share anything more about? I will just try to contact the next speaker immediately.
Sure, Dr. Geeta. We have screened, like Dr. Geeta mentioned, 45,000 women. And what we also did, part of this was ask women about their experience. And that is where Dr. Geeta came up with, a mentioned number of 98% of women getting screened for the first time ever in their life. And really happy that we are able to reach out to more women because of Niramai's thermalytics test. We also do camps for a large number of rural women, trying to cover as many as possible, because we believe that one person comes and gets the screening done, they're able to go out and reach out to more people. And our first, I wouldn't say target, but our first approach is to approach Anganwadi workers, Anganwadi teachers, ASHA workers, who are the human messenger to people whom we cannot reach in rural India, in remote districts of our country. And because of that, if I can mention, we did have a mega camp on January 26th of last month, of 2022, and where we screened more than 400 women on a single day. While this is a thing that we did not imagine to be possible, but thanks to good coordination and good support from the government and the government employees, we could manage such a thing. And all this while maintaining social distance, because our test, like Dr. Geeta did mention, there is an inherent space that is kept between the device and the person undergoing screening. So there's no contact, which is why even despite COVID, despite the pandemic, we could go out and reach out to people. She also did mention about home screening. So for women who are not comfortable stepping out during these trying times of the pandemic, Niramai's test is so small, so portable, it can be fitted in a cabin bag. That's how we call it. That could be taken and given, to the homes. So women did not even have to step out because this device is so portable. Unlike a bigger machine which needs a room, which needs, where radiation is involved, this particular device could be taken to a person's home in the comfort of their homes and screen for breast cancer. So I don't have the slides, but if anybody has any questions regarding Niramai's test, please take this opportunity to ask me. I'll be happy to answer them.
And the speaker is coming in a few minutes, but meanwhile, if you have any questions, please.
We are at this probably a rare thing where we are ahead of a schedule. Very rarely that happens. So I think that's a good sign. Anybody has any questions regarding anything related to breast cancer, not just related to Niramai's test? Please take this opportunity to ask us.
Hi, this is Umapai here. Just wanted to know, for the home visits, how much is the charge? What is the charge for, supposing I'm old, I live alone, so I had my breast surgery done 22 years ago, with God's grace, okay? But if I have to do it now, another test, I haven't done for 2 years, right? Because of the COVID, not allowed to go to the hospital.
Sure, ma'am. Yes.
So how much does it cost for a home visit?
Ma'am, I'll ask my colleague, Dr. Nandita, to contact you. Would that be okay? Because she handles home visits, and I'll ask her to contact you.
Okay, thank you.
I'll personally ask her to contact you.
Thank you.
And this was started mainly because, the COVID was the reason we initially started this, because we realized that there are many women, especially conquerors like you, who are not able to get their regular screening, which is part of your follow-up. And that is why the home screening started. So we'll make a note of it.
Yeah.
I have a question here.
Okay.
Yeah, go ahead. Go ahead.
With my 22 years of positivity living, I think the breast cancer, especially all of us, should also concentrate on pranayama, yoga. Pranayama has become such a sustained effort, for all of us, which has really helped us a lot. It goes a long way. Meditation
Sure, ma'am.
and pranayama, of course, along with positive and action oriented, like you have to be active. There are no two ways about it. You can't make an
Definitely.
excuse because I have breast cancer, I'm not going to live my life, because life is greater than cancer, right? So have to start
Definitely.
living more. In fact, age is also just a number, at least as far as I'm concerned, it's a number. I live alone from 17 years and I follow all the health protocols, eat healthy food, cook my own food, do my walking, my yoga, my exercise, and a lot of activities. I think that is very important now, whether online or offline. I think a lot of activities will keep us going. Okay, when we're having radiation, it's difficult to get into the kitchen and do any major activity there. But after that, I think we should go back and start living our own lives. You see, how long can someone else hold our hand? The best thing is to be self-reliant and then go ahead and make a fresh life of your own. Forget the past. You can't go on living in the past. Okay, this happened, now what next? No. You have to live for tomorrow, live for today. I think that is what I get. That positivity has kept me going, and my various activities in various fields, so that there is not a moment for my brain or for my mind to play monkeys with me. I don't think, okay, I've accepted it and that's it. Now we have to, everything is done and over with. So now you be happy that and count your blessings every day count your blessings. And that we need to move on, give us the strength to cope with all this. And we have coped very well, all of us.
Thank you, ma'am. Thank you so much for those very positive words. I'm sure it'll help all of us here. Thank you so much. My team will get in touch with you, ma'am. Thank you so much.
Thank you.
Thank you. Thank you for your patience. We now move on to the second most common cancer in our country, cancer of the oral cavity and lip. Who else to talk about it than Dr. Vishal Rao, who is the Group Director for Head and Neck Surgical Oncology and Robotic Surgery at HCG Cancer Center, Bengaluru. Dr. Vishal Rao is lauded for being the inventor of home voice prosthesis, a $1 speaking device designed for throat cancer patients. Dr. Vishal has been recognized by BBC, Harvard Business Review, and Forbes for his work on treatment techniques, drugs, medical devices, and theories, and has over 18 patents to his credit for his innovation in multiple fields. He has a keen interest in cancer prevention and tobacco control programs, and is also an international advisor to WHO's Tobacco-Free Initiative. Sir, the stage is now yours.
Thank you. Thank you very much.
Pleasure to have you, sir.
At the outset, I would like to thank Geeta and the entire organizing team for all your sincere efforts in this endeavor. Without much ado, I think I'll just share the presentation, and in the few minutes that I've been given, I will judiciously use this to keep the interaction as interactive as possible. I'll just share my screen. Today, I will be speaking about in principle, broadly on oral cancers, but because that's one of our key cancers, but also focus on head and neck cancer for the general audience. Thank you for this generous introduction. And again, I think between me and Geeta, we share a common journey in innovations. We've both been working on in the tightrope of innovation, trying to survive the actual innovation ecosystems. And thanks to Government of India, thanks to all the co-innovator founders, that we've actually been trying to live this journey. And I think one thing that today I would like to share with each one of you is that as a fundamental philosophy, when Geeta called me for this program and told me be a part of this, talk about it, I thought the one thing that I should start with is by saying that I had a department of head and neck surgical oncology pan-India, which should not exist. This department is preventable. This department need not exist. And my prayer and hope someday is that this department is going to be empty with less cancers. And that is where I would like to start this presentation with, saying that this particular group of cancers are preventable. They need not be here. And today they are there because of a larger aspect of habits and other things that people are living. You look at head and neck cancer, they comprise of nearly 1 in 3 cancers in our country, with about 2 lakh new cases each year, and 80,000 of them coming from the mouth. And when you look at these, the most common cancers, and I'm talking about one of the commonest cancers, which is oral, followed by voice cancers, sinus cancers. Look at the most common cancer in India. It has a dismal survival of 20 to 50%, about 1,45,000 deaths globally, and 50,000 of them in India. And primarily all of this happens because of late presentation, primarily. Now, we all know about the causes of cancer, and tobacco is at the top of the list: alcohol, dietary factors, dental hygiene, and viral factors. Now, when you look at the stages of cancer, stage 1, stage 2, we call them early cancers, but by the time it goes to the nodes, so I often say this, that it's like from the side road to the main road to the highway. Now the tumor wants to go from the side road, it goes to the main road, which is the lymph nodes, and from there it goes into the other organs like lungs and other places when it becomes stage 4 and beyond, when it is metastatic. The only one single thing that we know today is that it is preventable. And in prevention, there are 3 types. Can anybody tell me what are the types of prevention? Take a wild guess and tell me what are the types of prevention. I would request the audience, if anybody can unmute or put it in the chat box and tell me what are the types of preventions that you've heard about.
Sir, primordial, primary, secondary, and tertiary.
Perfect. So there are 3 types of prevention: the primary prevention, the secondary prevention, and the tertiary prevention. The primary prevention works on policy. The primary prevention works on preventing the root causes, which I was mentioning before. The causes like tobacco, alcohol, looking at dietary prevention, and other infections. The other aspect is related to secondary prevention, which is early detection, which is what people like Geeta's team are working on today, to bring together and pick up cancers early. The third is tertiary prevention, good surveillance so that you pick up a cancer early when it recurs, and educate people about the importance of surveillance. There are 3 aspects to cancer, and each of these aspects is equally important today. And the biggest and the most powerful fight lies with the first 2. It is most important today in many places, like for example, in tobacco or in head and neck cancers, we often say that if a cancer is preventable, that means at primary or secondary prevention, we will be able to pick it up early. That itself is the greatest contribution you can do to a cancer, because instead of picking it up at stage 4, if I pick it up at stage 1 itself, I have reduced 70% of the cost for the patient, direct and indirect, and I have improved his survival by 3 times. That itself is a great contribution. So if you look at the treatment related paradigms, you have basically, if it's an early stage, you need 1 modality treatment. If it's an advanced stage, you need 2 or 3 modality treatments. With that, these 3 aspects of prevention are equally important. And that is why it is important for us to understand early detection and secondary prevention along with tobacco control. I must share with you all, so all our efforts in this direction has been to understand what can we do to pick up the cancer at clinical, imaging, biopsy or immunological level. And today a lot of the world has been moving towards genomics, trying to understand from epithelium till cancer, how can we pick up the genomic instability in a more effective manner. And these are the kind of patients that we often see to try and understand how can we pick up cancers at stage 0. Now this patient came to us with a white patch in the tongue, which we call stage 0, not stage 1. So we picked it up at 1 stage earlier, not stage 1 also, at stage 0 when it was pre-malignant. I often say this, that when the raw materials are being gathered and the product is not yet ready, it is at that time that we pick it up, the best outcome and the best value for money. And that is where screening should be moving towards, to make it cost effective to save lives. And in this, again, high risk individuals should be the ones who should be taking it up. Now, we all know that prevention is better than cure. And today, cancer, we know in the coming years, maybe almost 1 in 3. Infection, diet, physical activity, stress, weight and obesity, radiation, environmental pollutants, tobacco, all playing a role. The one thing that I can tell you, my friends, here is today we know infections like HPV in head and neck cancer are known to cause cancers. The changing sexual practices, the unhygienic environments, and added to that, today the information we know that infections causing cancer is a reality. In diet today, when we talk about diet, we are talking about diet and nutrition separately. I would urge all of you to read this op-ed I had wrote some time back. If you Google it, you will know. In the Better India, it was called "I Don't Drink, I Don't Smoke, Why Me?" About food safety. Diet does not mean nutrition. Today we are having good diet, but nutritional value is low. In terms of nutritional value, when I say proteins, vitamins, minerals, fibers, which are the most important for the body, are lacking. Lack of physical activity. Today we know that sitting is the new smoking. And unfortunately, we do not have an exercise patterns to us. I'm just sitting today over here, and I must tell you, below my table over here, I use an under-desk peddler. So I use an under-desk peddler, which keeps my foot pedaling. So as I'm talking also, I have my leg on the pedal and I keep doing this. So physical activity is vital. How many of you all here have faced stress at some point or other in life? Stress is a common factor in everybody's life today. How many of you all here in the audience can tell me that you have experienced stress at some point? And how many of you all have not experienced at all? I think it's better to ask how many of you all have not experienced. You can put it in the chat box that you have not experienced. Okay, so Dr. Amita Singh is saying that they have experienced stress or not experienced stress. So how many of them among the 96 would have not experienced stress at all? I have a new message, experience. Okay, so Dr. Amita Singh said that they have experienced stress. So I think if I tell you in the 100+ audience today, I would say 99 of us would have said that we've experienced stress. And I'm not going to go too much deep into this, but stress has become a part of life today. The question that we need to rework in our next generation for the new society is, how can stress become a healer, not become a stressor, not increase the biological stress in the body, and how can this metabolic stress be reduced, the physical, the mental, the biological stress be reduced by looking at a higher level of acceptance and less expectations. I believe the key mantra to stress is the lesser the expectation, the higher the acceptance, the lesser the stress. Similarly, weight gain today, we know obesity is one of the key causes of cancer and one of the key contributors in cancer. So we need to look at connecting obesity, weight with physical activity and diet. Environmental radiations, ionizing radiation, non-ionizing radiation, mobile phone towers, looking at all of this, there are a lot of concerns rising. We are in an environment filled with carcinogens, environmental pollutants by itself being an independent factor, and then later tobacco. So all of this put together today is going to create a lot of concerning things for us on tobacco, on cancer and its impact on the society. So I'm going to touch a little bit more in deep on cancer causation and on tobacco. Now, what is important here for us to know is tobacco comprises of 95% of the problems for head and neck cancers. It has about 6,000 chemicals and about 70 carcinogens. I want to ask a question to our audience. Think of it. Why does tobacco leaf doesn't have so many chemicals? Why does tobacco products have so many chemicals in them? Can you think of it and tell me an answer on why do tobacco products have so many of these chemicals that have been added to them? Can somebody take a guess and tell me? Why would tobacco companies add so many chemicals into tobacco?
To make it addictive?
Absolutely. Oh, sorry, who said that answer? That was very...
Lakshmi.
Thank you, Lakshmi. So that was spot on. So the most important thing that we need to know is the tobacco companies run the nicotine business, not the tobacco business. Nicotine is the most powerful and addictive substance known to mankind, and 1,000 times more than heroin. And it is the best business model available to ensure that you get customers. Now, for example, let's say that Geeta and Lakshmi decide and inform all the audience today that we are sending you a cigarette and we are mandatorily asking all of you to smoke the cigarette. So 100 of us start smoking today, mandatory because of this session. How many of us would be long-term users? Take a guess and tell me, at 1 year, if Geeta forms another session, how many of us will be still long-term users?
No, won't do it.
No, yeah?
More than 50% get addicted to nicotine.
More than 50%. The tobacco industry knows that it's at around 30%. And that is what data shows, that if 100 of them consume it, 30 of them will become long-term users, roughly. Now, this has to do with the critical dose of nicotine, on how much nicotine you will take per day to build up your addiction. And this is at around, roughly, I'm saying about 3 milligrams to 5 milligrams of people would require nicotine per day to give you a long-term addiction dose. But the tobacco industry often works on understanding and adding more chemicals that will improve the delivery of nicotine, because you cannot increase the dose of nicotine beyond a certain point because it is dangerous and lethal, because nicotine is also considered and covered under the Poisons Act.
Yes.
So today we see between us one of the most important friends and companion of tobacco is alcohol. Alcohol is the greatest friend for tobacco, and they both go together whenever they go, most of places. I'm not here to support alcohol, but I'm here to tell you that both of them are good friends. But between both of them, if you see, the tobacco is the greater evil, because it is not that a person drinks at the beginning of the day. It is not that the person starts to drink on the day of the beginning, but a person who's a smoker may want to use tobacco before he goes into the washroom. And that is the kind of thing that addiction is there with tobacco, much, much higher than alcohol. And alcohol has one carcinogen, tobacco has about 60 to 70 carcinogens. I'm sorry, there's been a power failure. In case it gets disconnected, I'll reconnect. So today, we know that tobacco affects every single organ in our body. Be it the lung, be it the trachea, be it the eyes, be it the teeth, be it the abdomen, every single, because of so many of these chemicals. Now, why am I telling this? Because today, if you look at all of these chemicals and if you look at the amount of diseases that are caused, the 4 important diseases caused by tobacco, among which one is cancer. And I'm not going to go drag this story because we all know about tobacco. But what is important for us to understand is this is what we deal with on an everyday. And that's because of chemicals like arsenic, nickel, chromium, active radioactive plutonium, benzopyrenes, formaldehydes, that we have to deal with these kind of problems every day. So on one of these programs, a few years back, I had asked our Honorable CM, Sir, Mangalore, there was a plane crash, May 22nd, 2010. Do you know how many people died in it? Can somebody take a guess? How many people died in this plane crash? I come from Mangalore, and this was one of the most tragic events that was witnessed there.
I think all of them from the plane.
About 167 people died. Now, for me, imagine that if every day in the headlines of the newspaper, we read a news that 167 people in Karnataka died. Would we plan to build a hospital nearby? Or are we going to find out what is the problem with the airport, the tarmac, or with the engine and study the black box? That is what today the black box of cancers need to be decoded. And that black box has one of the topmost names, that is tobacco. The black box of cancer has tobacco as the top list, where in Karnataka, nearly 150 more people die only because of addictions of tobacco. That is what we currently fail to understand and address today. That the health burden, for example, in Karnataka, we have almost nearly 2 crore consumers, of which 66 lakh people will die a premature death. And the financial burden of this is about 4,000 crores per year that the government will be spending on 3 diseases, heart, cancer, and lung, only because of tobacco. So at this juncture, I'm not going to go deeper into the subject, but I think I would like to close with one, we've been doing a lot of awareness program. I want to close with one single note. I remember a very interesting meeting. One of my friends, he has become a Bollywood director, and he was in Mumbai, and he had invited me to his home for a dinner. And he had done his medicine and then moved to Bollywood. So while in one of those dinner meets of his, a lot of Bollywood people were there, and I was interacting with one. He told me, Vishal, he said, I don't want to introduce you as Dr. Vishal because it's quite boring. I'd rather introduce you as because DR ka yahan pe DJ se izzat kam hai. DJ has more value than DR, so I'll introduce you as Vishal. So I was interacting with one director as Vishal, and this man started to smoke. He threw a couple of puffs on my face and he blew it, and I was a little uncomfortable. So he looked at me, he realized that I'm uncomfortable. So he smiled and told me, he said, Vishal, take a chill pill, and he says, take a drag, enjoy life, you live only once. So I just politely refused, and we continued our conversations. But at the end of it, I gave him my visiting card and I told him, sir, if you ever need me for any help, think of me. He got very upset with me. He got very disturbed and he said, oh, I didn't know you're an oncologist. I didn't realize that you are doing this. I'm so sorry. He said, but you should not have played this joke on me. I said, when you blew those 2 puffs on my face and blew the joke on me that you live only once, I thought I should have my chance of playing my joke on you. So we both have shared a joke now, and 6 months later, this gentleman came to us. He came to Tata Hospital with a swelling in the neck. Luckily, it turned out to be tuberculosis, but that 2 hours he spent at the hospital, that amount of frustration he went through, I think was a testimonial for him on what happens in reality, that at the end of it, when you get these diseases, you are all alone. The people you party with, the people who are at the gate with you smoking are all not there. Your relatives are not there, your friends are not there. And the only way we can change this kind of a setup is by doing such programs, taking ownerships, coming together and making a difference. And we have now launched the Karnataka for No Tobacco program, where we work with children, we work with Bosco Street children and several other children to actually raise awareness on cancer. we've created a 5-minute quit program at HCG to help people, motivate them quit tobacco. And I'll close with one video from our side, and then maybe open it up for any questions. Thank you very much for this opportunity, and I think I'll close with this and open it up for any questions or comments at this juncture. Thank you again, Geeta, for this opportunity.
No, that was an excellent talk, Dr. Vishal. Thank you so much for that. Any questions from the audience?
I think Saubhagya has asked, can we use Nirmai's thermolytics to detect oral cancers in head and neck? And I think that's something that Sudhakar has been picking my brains on and telling that we can. And he said because of the heat sensitivity, we should be able to. In fact, I have been encouraging him and telling him that we should start some small study on this and actually roll it out. I think very much possible for us today to do this. And this would also give us an opportunity to innovate and understand, rather than say why we can't. I think we should be able to answer why we can. It'll be like the new age sentinel node before you go in. Like before you sending them to the nuclear medicine, if you send them to the thermolytic department, it will be better than that to pick it up and send it.
Absolutely. I think we've screened some 20 people so far. Hopefully we will improve this number and then start this. And that's excellent collaboration that started after both of us won the National Startup Award for Health.
So I think Saubhagya is interested in doing this as a research. You should connect her with Sudhakar. We should be able to do this together.
Sure.
I just wanted to ask this module which we are taking to different schools like Don Bosco and others. Doctor, how
yes,
do
madam.
we it? Whom do we contact? Supposing I want to go to, there are a lot of, on Sajipur Road, we have all these elite schools.
Sure.
Public schools, what they call. And there the children are the ones who come with a lot of money in their pockets and they all want to experiment, right?
Sure.
At that age, 15, 16 years, is only the bravado sleeps in, and my friend is doing, why not I take a track, as you rightly experienced in Mumbai. So where do we get hold of this to, take it to our other elite schools so that they also get educated? Don Bosco, yes, I know them very well.
I'll connect you with the Karnataka for No Tobacco team, KNOT, not team. You can connect with them and discuss this and take it forward, madam. I'll message you their number right now.
Okay, thank you, doctor. Thank you. Because I thought we as educated class and who have our grandchildren, nephews, nieces studying in these so-called public schools, they're very Americanized also. And I think America is also leading an example for all this for our children, like the Coke and Thumbs Up and things like that. So I thought they also should get exposed to this, And de-addiction centers, how many do we have here for tobacco de-addiction centers?
Madam, the best one we have is in Nimans and spearheaded by our director herself, Dr. Pratima Murthy. I think other than that, HCG, we have our own de-addiction center, and many other hospitals offers de-addiction programs. We've in fact structured a very nice program where we do a 5-minute quit program with the people, not to kind of bore them with gyan and telling them why they should not, which they already know, but what makes them do it. And that's the kind of a reverse thing that we use in reverse addictions formulas we use here.
Okay. So except Nimans, this south side of Bangalore, we don't have anything, right? Really?
No,
People speaking them?
and most of what we are doing here is all online. So I've messaged you already the number of the person. So I will ask him to reach out to you shortly and take this further.
Thank you.
Thank
Because
you.
as you
Yeah.
rightly told in
Thank
one
you.
of our meeting, that we need to now a lot of awareness has been created already about breast cancer. I think all of us done a lot of work in that field. Now I think this is really worrisome. Tobacco addiction in youngsters and in a lot of ladies that too, of late.
Spot on, spot on. And I think I fully agree.
Yeah, I think this is one of the preventable ones. Any comments on screening, like other type of head and neck cancers, like throat or thyroid, or like how do people know about symptoms for this?
Correct. I think very broadly, what I tell them as a formula is, remember, screening is an important thing, can be misused. I don't want to present to you here that everyone across the world and every individual should screen himself, because that would be misuse of a tool. However, there are important indications to screen. The most important thing that you should look at when you're talking about screening is, you are talking about risk profiling. If you are at high risk, you are at the top priority of screening. And if you are, what do you mean by risk factors? Age is a risk factor. Certain times the sex of an individual is a risk factor. Certain times habits is a risk factor. Lifestyle itself can be a risk factor. And that's why it's important to highlight, based on the degree of risk factors, you need to prioritize it. Screening by itself can otherwise become a misuse of a tool where you unnecessarily screen but don't get anything and get paranoid. So don't get paranoid, but yes, screening is important. Don't neglect it also. Now, what's the thin red line? The thin red line is risk category. And that's why there are global guidelines that have actually beautifully enumerated what are those risk categories, follow them very simply. But in addition to this, what's also important here is the biggest tool we have in our armamentarium is screening, to pick up a cancer early. Now here, there are 5 aspects to screening: clinical, radiological, then we have biochemical, blood related, genomic, and we have endoscopy. 5 things that we have in our armamentarium. Clinically, simple mouth screening, cervical cancer screening, breast screening, clinically can be done. Self-examination tools are there, AI tools are there. Number 2, we have, in addition to that, radiological, whole body MRI, or related to specific low-dose CT scans of the lungs, a simple X-ray could be good radiological screening. Ultrasound of the neck for a thyroid cancer would be a good screening tool. Third one, related to biochemical, there are blood markers for males, for females, for common cancers, which are tumor-specific blood markers that can be done. Fourth, in addition to that, we have genomic, hereditary related blood cancers, which are hereditary related tumors, can be picked up through genomic screenings. And lastly, endoscopic, for specific people with suspicion, endoscopy could be a tool. So there are 5 arms to screening, and these 5 arms has to be judiciously used based on risk profiling.
Dr. Geeta, you're on mute.
Yeah, I just said thank you. And I think there is an audience question, but I just want to mention that we are actually developing automated risk assessment service. So we'll come to you to sort of fine tune it for oral, and this for all cancers we are developing. So we'll come to you for that.
Sure.
Yeah. Dr.
So the question is, what are the causes for eye cancer? Could it be a secondary one?
So eye cancer has been a very, very complicated area. And one of the things that has been driven, retinoblastoma kind of tumors, pediatric tumors, have been all driven on genetic. And that's where I would like to re-emphasize here that cancer is a genetic disease. However, not a hereditary disease. Now, this is the complex ecosystem that we are in, where we now know that cancer is a genetic disease, but not a hereditary disease. In cancer, genetics plays a key role in almost all 100 cancers, but only 5 of them will be hereditary. So here itself, there are key contributions that genomes have been analyzed to understand how each one of these cancers can be looked into and why they happen. Now, the 95 of them are because of somatic genes, genes that mutate because of our environment, because of what we bring in from our environment, or because of a defective repair mechanisms that we either are born with, or that we are transferred to from our family, or that we acquire from the ecosystem.
Right. Thank you, sir. I think Saubhagya has a comment to make. The majority of the dental colleges have tobacco cessation centers, public dentistry, and this happens in all dental colleges. Even I'm aware of that. So this is in response to, I think, Ms. Uma's question.
So just one more thing that I want to tell is de-addiction centers in principle have a quit rate of 6% at 2 years. That means 94% of them will not quit. The reason for this is that the will's power is more powerful than willpower.
No.
And that is why Godfrey Phillips, one of the world's biggest tobacco companies, runs its own de-addiction center. So it's a complex game. It's not easy.
Very true, sir. Very true. Thank you so much.
You know, we are running our program on reverse addiction, which is also with a part like how the Allen Care program runs, which is actually on a quick de-addiction plan, quick de-addiction plan.
Okay. Wonderful. I think it was a super good talk, Dr. Vishal. As I'll always, I'm a super fan of multiple innovations. I would love to hear more. And, I want the audience to hear more about your innovations also, maybe another time. So we'll have a full one from you. And thanks a lot. It was a privilege to hear you.
Thank you. Thank you, Lakshmi. Thank you, Geeta.
Thank you, sir. Thank you for the very insightful talk and stressing the importance of prevention, which is as not arguably the single most contribution to reduce oral cancer. As an oral pathologist, I share your vision of having an oral cancer-free world. Thank you.
Very kind of you. Thank you.
Thank you.
Thank you so much, sir.
Our next topic for the day is cervical cancer, the third most common cancer in India. There was a time when it was the top cancer, just as recent as a decade ago. To enlighten us about the disease, we have with us Dr. Sundari Nandiala, an obstetrician and gynecologist, who's working tirelessly towards the awareness and prevention of cervical cancer in Karnataka through her trust Mahati, and is also involved in various multi-center trials and rural projects to screen women for pre-malignant and malignant lesions of the cervix. A founder member of the Medical Education Department at MS Ramaya Medical College and Hospital, she also holds a diploma in medical law and ethics and consults at Rural Development Trust, or RDT, at Andhra Pradesh. Over to you, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am, you are. Do you want me to share your slides or?
I'll try to share. Shall I share the slides?
I can share it for you.
I'm doing
Yes,
it.
ma'am, you can share.
Okay.
Yeah. Is it okay? Is the slide seen?
Yes, ma'am. Now it is.
Okay. Thanks a lot. And at the outset, I thank Geeta Manjunath and Dr. Lakshmi for inviting me for this wonderful awareness program. And stalwarts have spoken about breast cancer as well as head and neck cancer. I've been listening to both of them. Of course, Somu, very close to me, a friend of mine, I know. Dr. Vishal wonderfully brought out the oral cancer, regarding oral cancer and tobacco. Now, my job is to talk about cervical cancer, which is very close to my heart. Okay. Now, without wasting time, let me just start it off. This is a cancer awareness. It is, everybody says early diagnosis and then give the treatment, especially the breast cancer, and the survival rate is 100%. But I don't say that, but I say prevent the cervical cancer because it's one of the preventable diseases. Maybe among the women cancers, the only preventable cancer is cervical cancer. This is the flow of my topic. Probably if I have time, I will try to touch upon all these things. Imagine just being a woman. We put ourselves into the risk of having a little more cancer, few more cancers than men, because we have the cancers what all men can get, but these are the special cancers what we get being a woman. Okay, women are always special. Women is special, of course. I know in many ways we are special. So we also have a special cancers for that. Among all these cancers, we talk about breast cancer has been spoken because that's one of the leading cancers in urban areas of India. And when we go to the rural, still the cervical cancer is the leading cancer. The most preventable cancer, unfortunately, is the second most common cancer in our country. Okay, so now we'll just go about and see what are the special features of the cervical cancer. Everybody says early diagnosis, treatment, 100% success. But I go a step further and say that prevent cancer. This is 100% preventable. And you know what? It is sexually transmitted disease. Can we believe it? Yes, we have to believe it. A woman who has no sexual activity in her life will never get a cervical cancer or a vaginal cancer, vulval cancer. Okay, so it is caused by a virus. Dr. Vishal was talking in his talk saying that head and neck cancers are caused by a virus. Same virus, human papilloma virus, is the main cause for cervical cancer. How is it transmitted? It is transmitted by sexual activity. Starts as a pre-malignant lesion, which is very easy to diagnose and very easy to treat. And then from the pre-malignant to malignant, if it has to go, it travels 10 years. Imagine 10 years, maybe at the 60s, 20, 25 years, the girls would have had a pre-malignant lesions in their cervix. By the time they get their cancer, it's 40, 45 years. That much of a time we have to screen them and prevent the cancer, because the successful treatment we can give, very simple way we can do treatment for the pre-malignant lesions. Now, when we talk about these are the women cancers, which I again put it, when we talk about all the cancers, say that universal screening, no, but only the breast and cervical cancer we have. In a breast cancer, this is universally we are screening them. The screen methods are, we have given, of course, breast cancer, you heard about it. Here, what happens in the breast cancer, you see early detection by screening also, you're doing early detection. Whereas look at the cervical cancer, 100% prevention. I don't think I need to impress any one of all the viewers more than this about the cervical cancer. Having said that, look at the global scenario and the prevalence of this cancer, incidence of this cancer. All over the world, it's the fourth most common cancer. Every year, about 6 lakh women will be diagnosed. Among that, 3 lakh women will die in various countries. Okay, by 2050, what is estimated is more than 1 million new cases of cervical cancer would be there with us in the world. Now, what's a burden in India? Let's see. Second most common cancers, 1/5 of the world cervical cancer burden is with us. Please see this. And in 96,000 cases, it was 1 lakh and around. Just now, 2020, we have, because we are telling that cervical cancer incidence is coming down, we say, though it's in the urban, because of the registries say, the rural, it is the same. So incidence is 14.7 per lakh. 6 lakh and odd deaths occur every year, contributing to 25% of the world cervical cancer deaths are with India. Imagine what is the magnitude of the problem we have. 1 out of 4 deaths of cervical cancer are from India. Can you imagine? Now, why is this? Every 7 minutes, 1 woman dies of cervical cancer in India. What is the reason for this? The main reason is awareness. Though we say that prevalence incidence is dropping in India, it's a very encouraging thing, but it's not so in the rurals, because the cervical cancer is more common among rural women than urban women. What is the main reason is the lack of awareness. You say lack of awareness among whom? Even I say among even the doctors, even gynecologists sometimes. Because awareness means we knowing that we have a cancer, I know cervical cancer is there, treatment is there. That's not. What is it we are contributing to the society when we know that it can be preventable disease? That's why I say even gynecologists are not aware, because many of them are very busy with their practice. They don't have extra 5 minutes to talk to every woman who comes to them for any disease. Just say that you just get a screening for cervical cancer. That's what I say, commitment from the health workers. We need to commit ourselves, saying every woman who comes to us must have a cervical cancer screening. How many of us are doing? We have to introspect that. National policy is there. National policy is there, that non-communicable diseases policy, but how much is implemented in states? In Karnataka, how much it is implemented and how successfully it is implemented is introspection again for us. And then lack of infrastructure and finance. If I have to do HPV DNA, I'm struggling to get it, but there is no infrastructure, there is no finance for me to do HPV DNA to every woman whom we see. This is exactly what we need, the awareness. There's an interesting study was done in the South India to know about the knowledge about the cervical cancer and its screening. See how many people have got. 5.1% have got the good knowledge. 84% of them have no knowledge about it. So where do we stand today? What do we need to do? We only need to create awareness. Like a polio, how it was being created, because national level, it has taken up. They created the awareness for polio. Now polio is eradicated from India. Why can't we do cervical cancer? Next come, who gets a cervical cancer? That's a big question what we have. This story, if we go, I think most of us are 40s and above, they know there was a big show on the TV, Big Boss. In that, Shilpa Shetty and Jade Goody had a big fight and it became international. I think if you remember, if you go to her life, just see that she's born in 1981. She had a multiple sexual partners. Through one or two partners, she has got 2 children at the very early age. 81 born, 2003 and 4, she has 2 children. Now she came to the Big Boss in 2007. Okay, Shilpa Shetty and Jade Goody. And at that time, when she has come for this, she was in India at that time, 2002, her pap smear was abnormal, but she never took care of it. And then while she was in Bombay again, for the time Big Boss 2008, she was diagnosed with the cancer cervix and she was flown back to her country. And 2009, she has no time to recover from that. At age of 29 years, she dies of cervical cancer, which is the 100% preventable cancer. What did we learn from her story? We learned everything. That means what are all the causes for cervical cancer? We have learned from her. Early age sexual involvement, multiple sexual partners, early age, children have been born to her, and then she has neglected when there was an abnormal pap smear. It's a real tragedy. So these are the women, any woman. There is no social discrimination for the cervical cancer. Though it is a little more in the villages due to various factors, everybody and anybody can be affected. Who is sexually active and who was sexually active also can get affected. And these are the people who will get affected more than other people. Just like a Jade Goody's story, when we remember, this is all the reasons. Smoking. It is not only the tobacco for the oral cancer. Please remember, it is one of the important factors for the cervical cancer also. Though endometrial cancer, it may be a preventable thing or it will really prevent endometrial, but the cervical cancer, definitely smoking is associated. Then coming to the how does it run families? Yes, it's not a hereditary, but definitely there's a genetic abnormality. So this is one family. Somebody is missing. You know, this is grandmother and this is the granddaughter. Who is missing here? Her daughter and her mother are missing. She died of, all 3 had the cervical cancer. The mother died and these 2 are the survivors. It's a very interesting story. Many a time we say breast cancer, I think Somu would have spoken about the food and food habits definitely will cause. But fortunately, the cervical cancer, there is nothing, the food is not implemented as one of the cause. But anyway, for the health, yes, food is always important, what we talk about. Now, coming to this, the virus. This is the main factor which causes 80 to 90% of the cervical cancers are caused by HPV virus. Now, what is this HPV virus? You know, all of us would have had this corns in the fingers, in the neck, in the palm, sole of the foot, we get it removed, corn removals, all the same virus. But the virus which causes all this is the strain is 11 and the 6. But whereas the cervical cancer, these are all the strains. It has got 100 strains. This virus has got 100 types. But the type which are most important and dangerous for us is 16 and 18. This is the one. What happens? Luckily, every woman, 80% of the sexually active women can get infected with the virus. See, that is a nature also plays. Depending upon our habits, lifestyle modifications, environmental factors, all this, it will be transient and asymptomatic in most of the women, and it will regress by itself. It clears out by itself. In a 20% of the people, unfortunately, it will be in the vagina. See, this is not in the blood. This virus is locally in the vagina, on the cervix, it will be there specifically for a long time. It will be there. Slowly, it starts getting the changes in the cervix. This is called a low-grade cervix epithelial lesions and high-grade. And then out of this 20%, 20% of the women will get the cancer. That means 80% of them can clear off their infection by themselves. So it takes 10 years, as I've been stressing on, from the pre-malignant, from the time we get infected with the virus to get a cancer, it is 10 years. The window period is very, very wide for it. So catch the woman at that time and then see that they have got the infection. If they are infective, they have the infection, HPV infection, do something, probably that's the cure for them. See, this is the clean cervix, how it looks like. It may start like this. This is not even we can't look at it. This is only by microscopy. Slowly it starts, it spreads and spreads. The whole cervix, if you do like this, it will spread. From microscopic to macroscopic tumors we get. Now, the symptoms, when I talk about it, only at this stage, woman gets the symptoms. These are the stage, unfortunately, symptoms are not there. If a woman has got a symptom of cervical cancer, that means it is an advanced infiltrating cancer. Okay? There are absolutely no symptoms in the early stage, in the pre-malignant lesions, absolutely no symptoms. That's why we have to screen them to know whether they have this problem. The white discharge is the most common symptom because this is a tumor. It is shedding the lot of secretions will be there, infection will be there. So white discharge and the bleeding, abnormal bleeding. It could be postmenopausal bleeding in a woman with menopause. Just a week back, I had a patient, unfortunately, and yesterday I diagnosed one and they sent me a report on a WhatsApp to see. Again, she is having a problem. Last week, believe me, in 15 days, this is a third case I'm diagnosing. My heart bleeds when I see one cervical cancer like this. And all coming up again, even now, they come in an advanced stage. Intermenstrual bleeding, acyclical bleeding in a reproductive age woman, postcoital bleeding. These are the bleedings in a reproductive age woman. Premenopausal woman should never neglect and see a doctor, and a postmenopausal woman, whenever she has got bleeding, she has to see the doctor. Okay, there's a blood discharge, back pain, urinary symptoms, swelling of the leg. These are all advanced stage of cancer. Very unfortunate. So we should not see any woman in that stage. See, this is a clean cervix. It should look like this will be the tumor. This is the time when they come with symptoms. Okay, the clinical signs depends on the stage of the disease. The first thing, all the doctors nowadays, because of the technology improvement in the ultrasound, our youngsters are forgetting to put a speculum and examine the patient. So much so the patients, when they come, madam, the scan report is there. No, please see and then treat me. Many of them started refusing even a vaginal examination, because I do agree, it is very sensitive one. It's very painful for them, or they don't want to. But unfortunately, nothing like looking at the cervix once with our naked eye, nothing can replace that. And we should not forget about it. If the doctors are there among the audience, yes, please, 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 any woman, convince them and ask them to get one speculum examination. That gives us a real information about the cervix and many things we can diagnose, like a breast examination, not the ultrasound, just a clinical breast examination, how helpful it is for us. The same way, the speculum examination and the bimanual examination. What happens when the cervix comes? If there is no cervix, no problem at all. We are very happy. But few unfortunate people, it progresses and goes to the vicinity of other organs. This is the uterus, it goes to the bladder, it goes to the rectum, it goes to the ovaries. And what happens? Foul smelling discharge, so much so that the people in the house will not tolerate them. They'll have such a foul smelling discharge. In the villages, it happens. Madam, this chikka mane, madam, we can't keep her. Daughter-in-law comes and says, I can't keep her in the house, madam, because she'll be smelling. And then the urinary incontinence. And then the severe, I had one young girl who had all the dreams of her life. And she had advanced cases because early cancer, when I told her, early, very early it was to get it treated. She says, no, I have to get a child. She went to some other medicine, alternative medicine. And exactly after 1 year, she walks into my clinic at this stage. Severe backache. I got her admitted, gave some palliative therapy, nothing helped. We lost her in a month's time. The anemia, and this is the way. It doesn't kill like a myocardial infarction or a heart attack or a road accident. It kills inch by inch. We have to suffer this. So what the WHO said is 2018, suddenly I started this program of prevention in Chikbalapur district in 2011. Suddenly the WHO opened eyes and said, why can't we eliminate cancer cervix from the world? That's what the WHO declared it, because it's a sexually transmitted, virus-induced and totally preventable cancer. So we need to eliminate. Now the Australia said this is going to be the first country to eliminate the cervical cancer. I think General Tedros, we have been seeing him because of the corona very often on the TVs. And then he is talking, the same person said, eliminate cervical cancer. And the FIGO is one of the international body for the gynec and obstetricians. They pledged and they took the declaration they gave that we have to eliminate cervical cancer. By 2030, the target is 90% of the young girls have to be vaccinated, because we have a vaccine for the cervical cancer. I don't know how many people know about it. 70% of the women would have been screened for cervical cancer by whatever method which is feasible and possible. 90% of the women who have cancer have to have a proper treatment. So the thing is 30% reduction in the mortality of the cervical cancer is the target, and we need to screen. There's a huge burden on us. And again, I take this opportunity to thank Geeta Lakshmi and her team to really bring in this awareness to the people, because this is what we need to do now. Is it possible in India? There was an interesting article in the Lancet Oncology. Okay, they said that if we start using the primary and secondary preventive methods by 2079, probably India can think of eliminating cervical cancer. Anyway, I will not be there. Okay, though I wish to see the day in India where there is a radiotherapy units are going free without any patients, and then there are no cervical cancer. That's my dream, at least for the Karnataka I have to do. Okay, now how do we do prevention of the cervical cancer? The primary and secondary prevention, lifestyle modification, regular screening and vaccination. These are the things, again, somebody said beautifully, primary and secondary prevention. This is the primary prevention. We do have vaccination for our children now at up to 15 years, 9 to 15 years, we can use 2 doses of vaccine for the children. Even 1 dose of vaccine is also to be effective. That's what we have brought in. So I'm requesting everybody, we have to get it by the government. I am fighting with the government to get into the schools, in our schools, at least 1 dose for all the children. Okay, below 15 years. After 15 years, though the vaccine is advocated up to 45 years by our national body, but very effective, it should be very effective is below they become sexually active. So up to 26 years, it can be okay if they are not sexually active. This is the way we have to give 2 doses below 15 years, after 15 years, 3 doses of vaccine. Now, what is screening? Now, lifestyle modification. What is this? This is all very common now. I work in one OPD where all the girls come to me, and believe me, every girl is sexually active. Very few girls say no. If they have to say no, means they are surprised to say no. Otherwise, it has become a common fashion for it. Not only a single partner, but multiple partners. And teenage pregnancies because of that. Okay, they involve themselves sexually into the sexual activities, but they don't know how to protect themselves from pregnancy. That awareness they don't have. They don't go to the doctors and ask for a contraception. So this has to be taught to the youngsters now, because we can't say don't be sexually active. I think we have gone beyond that stage in India. Every girl is sexually active, whether it is villages or whether it's urban, whether it's a Bangalore or Chikbala. Okay. Now another thing is obesity, and the smoking has to be stopped, because this is one of the promoters to the cervical cancer. Now, how do we do the lifestyle modification? Monogamy is better. Regular exercise, regular food habits. Now these things have to be stopped. Small family, and of course not a very early childbearing. Okay, say no. Okay. These are the things, the lifestyle modifications, which can go a long way to prevent the cervical cancer. Okay, now coming to the screening. What do we mean by screening? We have been talking about screening from morning. Screening is a systematic application of the test to identify a disease in an asymptomatic individual. That's a problem comes there, because the person comes to the doctor when they have symptoms. As I told you, the cancer cervix, once the symptoms are there, it is very advanced cancer. So they must come very early. Asymptomatic, that means all women have to be screened. There is no high risk or a low risk. Every woman who is sexually active has the risk for cervical cancer. So we need to screen all of them. The mammoth, this one for us. Okay, it's a thing. Now, what are the tests? There are many tests which we have to screen depending upon the resources and then the affordability of the patient. The age is the 25 to 65 years is the age. Our national body has brought it down. I mean, from 30, it was initially, and now it has been brought down to 25 years to 65, because The world age limit is this. Now, beyond 65 years, we don't need to do if they had a previous smears or previous screening being negative at 65, they don't need to undergo screening. And if the women are hysterectomized, if they had a previous screening and they had no problem, they don't need to go for a screening at all. This is where we don't, where I work in a rural area. This is the way we need to screen. Those are the tests for screening for them. There are many tests for screening. Important tests are the pap smear. All of you must have heard about it. Pap test or a pap smear. Now, this is a VIA, that is acetic acid. This is what you said is vinegar. Diluted vinegar is acetic acid, 5%. We put it on the cervix and see the changes. There is acetovoid change, definitely, that harbors the pre-malignant lesion of the cervix. Very cost effective, very simple, very fast. You can do this. Is what is promoted by the government of India for all the rural women for a population screening. Now, this is the sophisticated test HPV DNA, which has been promoted as the primary test by the WHO because it is a very, very reliable and objective type of test. When the pap smear test is not very reliable, what came up as an improvement is the liquid-based cytology. I'm not going into the details. And we have this. This is useful for the camps, okay? Mass screening, we can use automated screening machines are there. Now you can use it for that. This is artificial intelligence is used to screen the population. Now, coming to the HPV DNA, once the HPV DNA is negative for the 5 years, the woman needn't have to get a screening. Twice in her life, from 30 and 45 years in between, twice a woman gets a screening done. There is no need for her to go for a screening because especially if she gets HPV DNA testing, she will not get the cancer. Because I said HPV DNA after 10 years only the cancer comes. At 45, she doesn't have the HPV DNA. She is negative. She is unlikely to get the cancer in her life. So this is the advantages of HPV DNA. It's an objective test. It is not subject to errors, won't be there. And all the viruses which are there can be diagnosed by us. And it can be used as a primary screening, WHO says. A follow-up of treatment also we use. And whenever we have a doubt with the pap smears, we go for HPV DNA testing. But one thing is, please, we have to remember HPV DNA positivity is not equal to cancer. People can be HPV DNA positive. They get the clearance of the infection automatically, as I told you in a few slides before. And then only some people it will be persist. So, what is happening is in India, HPV DNA in Bangalore, they are positive, they go for hysterectomies. So that should not happen. That is not equal to developing a cancer, or they have already developed a cancer. These are the further advanced progress in the biomarkers they are, further progress in the screening. Whenever we have doubt, we use this. Then this is the simplest test, what I told you, how it looks like. See, if you put acetic acid to the cervix, it looks, we put an iodine, they look like this. This is iodine negative area. This is the white area, which will be the abnormal areas. See, these are the white areas. Different types of white areas. So it gives the severity of the disease. Okay. Approved clinical approach is this. Any of the tests which is possible, feasible, we can use. Only HPV DNA, because right now in India, it is very costly. In Bangalore, it's very costly. So I don't say that you have to go. Ideally, if you can afford, they can go for that. If not, any other test is okay. Now, see and treat and treat. Now the program has come by the WHO again. You see with your eye, suppose VIA you put it, there is positivity. Give the treatment then and there. Screen and treat. This is also one of the modalities because the people may not come back for the, again, for the screening and the biopsy. So what we are doing it, we can just treat them and there. It's a mammoth task for us, prevention. Anyway, still we have to do it. If all of us can put together our hands together and create awareness, probably we can eliminate cervical cancer. Now, I don't think I need to go. I don't have time, I think. The staging of the cancer, it stages, as Dr. Vishal was telling, all this is the modalities what we have to diagnose the cancer once it becomes a cancer. I don't like to talk once it becomes a cancer, how do you stage, how do you treat? No, I want to do prevention. I don't want any woman to have a cervical cancer at all. Then the treatment depends on the age and the performance stage of the disease and the company. Please remember, once it becomes an invasive cancer, whatever treatment you give, we talk in terms of 5 years survival. Okay, we don't say 100% you will be living all your, whatever Brahma has given you the lifespan. We don't say that. But whereas if you pre-malignant lesions, if you get treated, I will say confidently that yes, you live all your lifespan, you can live or whatever God has given you the life. Period. Okay. These are the various modalities of the treatment. And the success of treatments depends on the stage of the disease. Okay, that's it about. So prevent cervical cancer. How do we prevent? One of the ways what we are doing today. These are all the ways. Take the polio, how it has been eradicated. That's the only way. This is my trust. I'm trying to do what little I can do to the society through this awareness programs and the screening programs. It is not even tip of iceberg, we are saying it. But we should not lose heart on that. Okay. Okay, is it, I think, sorry for that. Okay. We can do together, all of us together, we can achieve what we need to achieve. I think the slides have gone somewhere.
So we are able to see.
Yeah. You could see this.
We can see, ma'am. Yeah, we can see.
Okay. What I wanted to say, the last word, what I wanted to say, a long way to go. But still, I always say, I may not be there, but I'm somewhere, no? Still, I'm somewhere. Yeah, that's okay. Somewhere is better than nowhere. So I say that something is happening. Okay.
Thank
you.
My
appeal, my sincere appeal to all of you is, please be a part of it. Okay, even a drop in the ocean. Okay, please part of it. Whichever way you can do it at your capacities. Please try to contribute so that all of us together can make all these women happy and eliminate the cervical cancer from our India, from our Karnataka first for me, and then of course India. Okay. That's it. Thank you very much. Again, I thank the organizers and I thank all the viewers for patient listening. Thank you.
Thank you, ma'am. Thank you so much. Your passion is indeed very infectious. I sincerely hope you've encouraged women to get themselves screened for cervical cancer. I have a very little experience with cervical cancer, but whatever little I have just one note to add. When we went out to screen women for cervical cancer, there was usually a taboo. Especially because some women had heard that this is due to multiple sexual partners. And they always had this taboo that if I'm getting infected with cervical cancer, that people will look at me as somebody who's had multiple sexual partners. And on that note, I would like to add, it is not necessarily it's only a female, but even a male could have had multiple sexual partners. And you, if you are one of the partners also. So it's not necessarily a blame game. Do not let that stop you from going and getting yourself screened. Nobody is going to do a character assassination. It is not just about you. It could be your partner also. So please go get yourself screened for cervical cancer.
Yeah, rightly you said, even with a single partner, if that partner has got a HPV infection, he will be transmitting. That's why 80% of the sexually active women can get. Most of us are not multiple partners. We may not have many of us, but still many of the housewives had the cervical cancer.
Exactly.
Because if the person harbors, the male partner harbors the cervical, HPV virus in him, he can give even monogamy also can cause it. That's why I said any sexually active woman is prone for cervical cancer.
Yes. Thank you so much.
And somebody has what is the ideal age for a vaccine. Ideal age probably around 14 years, you can give it up so the 2 doses only are needed. I always say 9th to 10th standard children because they also can understand what we are telling them, and then we can give off the vaccine. Same taboo. If they say, the parents are worried, if we give vaccine, okay, that's a license we have given for their sexual activity because they don't get cervical cancer. That's the way they think. No, even with that, they can get cervical cancer. That's why we say the people who have vaccine, still at their 30s and 40s, they must get screening also. Screening is not stopped. Right now, until now, at least, the research is still going on, whether we can stop totally the screening in these women who had the vaccine at their younger age group. They are being followed now, but still right now what we say is though they have taken the vaccine, right time and right doses, still they have to get a screening in their 30s and 40s.
Yes, ma'am. So vaccination is not a replacement for cervical cancer screening. It's only a mode of prevention for cervical cancer. Yes. Ma'am, we have a question here. She says, I am a 35-year-old woman married since 10 years. Can I still get the vaccination done?
Yeah, that's what everybody asks now. See, up to 45, Indian government, our FOXI body has approved the vaccine up to 35 years. You can take, but the note I give is you have to take 3 doses because you are 35 years. And the benefit what you get is not equal to what a 15-year-old girl would have got the benefit. Yes, see, suppose you have one strain of virus in you. Suppose you have been infected with 51, 52, 16 and 18, you are not infected. Definitely this vaccine is going to help you to prevent 16 and 18 infection, which is the most important cause for the cervical cancers. Contribution is 70 to 80% is only 16 and 18. So that way it definitely helps you. But already if you have been infected with the whatever is there in virus in us will not be eradicated by vaccine number 1. That will do its job of progressing and changing the cells into dysplastic cells and progressing into the cancer. That's why we say screening is not replaced. Because there are many viruses, 100 types, in that about 15 are really cancerogenic strains. So in that 15, whichever one you have, you may have one. With the vaccine right now, we had only 4 strains. The vaccine is quadrivalent. Only 4 strains have been covered. Now the nanovalent has come to India, which cost about 10,000 rupees right now. That covers about 9 types of HPV, which are all again carcinogenic. That may be useful. If you take that, yes, probably you may. But already if you are harboring virus in you, it will not be eradicated whatever vaccine you take. Nanovalent, a quadrivalent, a bivalent, whatever you take, it is not.
Okay. Thank you, ma'am. There's one more question that says, nowadays PCOD is becoming very common in girls. Does that make them have higher risk to cervical cancer?
No, PCOD makes you to the cancer endometrium. Endometrial cancer is very common in the people who have PCOD in their younger age group, but cervical cancer, no, it is not a cause, or it's not a risk factor too.
Okay. And vaccine help in the endometrial cancer prevention?
Beg your pardon?
Is there like because there are lots of women who have girls have PCOD.
PCOS, yes, ma. We say
so is there some risk, some preventive mechanism or like
yes. The lifestyle modification. Main thing is the weight and the food. These are the 2 things they have to change their habits. So much so, one girl has complained to her authorities that I told her it seems you have to reduce your weight. Can you imagine that? Why people talk about my weight when I go with the menstrual irregularity to a doctor? I mean, my concern is not today. My concern is tomorrow what she gets. She gets a diabetes, she gets hypertension. She can get a heart disease, she can get a cancer. How many cancers? Breast cancers and endometrial cancer. Just to prevent it. And she went and complained and I got a note from them. Madam, what happened, madam, this girl? I said, this is what I spoke to her. But I don't stop. Even if they complain, I'm not going to stop. 100 people, if I talk, maybe if 10 of them they realize it, I have done my job. Is it not? So that's the way it is. So endometrial cancer, whoever is PCOS, they have to keep a weight under check. And then at the very early age of 35, they must start getting screening. Like a cervical cancer, we don't have any screening modalities for endometrial cancer all over the world. It is not recommended. But having said that, high-risk women, and one of the high-risk factors is PCOS and obesity. There are 2 high-risk factors. This girl will have PCO. So those people have to get their screening even from 35 onwards.
Thank you. We have another question which says, after menopause, do we get cervical cancer?
Yes, we can get. Many people are getting it after menopause because they say, the proudly woman says, after my delivery, I have not gone to a doctor. They think that it's a very proud thing. No, please, unfortunately, it's not. At 70s, there is a bimodal. We say it's a bimodal. One is at the 30-35 years, the peak, it will come. Again, at 45-50 years is the one more time the woman can get cervical cancer. So it's a bimodal distribution is there for cervical cancer. So definitely they get postmenopausal.
Yes. And as you rightly said, ma'am, I think the awareness is so less. For example, my mother goes for a medical health check every year. A cervical cancer, breast cancer screening examination is never mentioned. I always ask her to add on to it. and go. So that's the level of awareness we are fighting against.
Yes.
There is a message which says screening of cancers to happen regularly at all taluka hospitals. We can diagnose early and better outcomes.
Yes,
Make
it has to
available
Has to happen.
always.
Not taluka hospitals, primary health centers. Put an acetic acid and just look at for 1 minute and say you are okay, you are not okay. That easy it is. Primary health centers also people can do. A lot of primary health centers, lady doctors are posted because I work in villages in Chikmadapur district now for my project. So a lot of female doctors are there. They can do that. Only have to see the mental, this one, we have to change the mindset of the people, which is very, very difficult. I'm fighting it in the villages. It's very difficult.
Totally understand, ma'am. Saubhagya is asking if you can provide any information about what you do, facilities available at Mahati Foundation Center.
Mahati, what facilities available? Sorry.
Facilities available from the foundation, from Mahati Foundation.
Mahati Trust is doing a free cervical cancer screening in the villages, population-based screening it is, and everything is free for them until the screening and the diagnosis. Unfortunately, if we diagnose a cancer, okay, we have sending to the Chikmadapur district hospital if it's early cancer. Anyway, one thing is now, anyway, they can go, but that I'm not sponsoring. But the screening method I sponsor until I give them the results. And some infections, meanwhile, while they come for the screening and all the drugs and all, we do that. After that, yes, it is not free, but it has to be borne by. But we are suggesting anyway. Chikmadapur district now the medical college has come up. Now I'm going to tie up with the medical college so that they could do a free of cost even the surgeries there for the patients.
Yes, there are also facilities by the government where you can treatment.
Yeah, there is this one, no, Prime Minister's.
Yes, PMJ and also. I'm sorry, I'm not.
One more is there for the cancers, especially there is a thing. You have the card. You can get anywhere, any hospital, you will get the treatment. Government hospitals, totally it is free. Even private hospitals, you get a lot of concessions for that.
Right. This probably is a question posted long back. Why can't government ban all tobacco and products? We can bring down mortality and burden on society and government.
It cannot ban because it's a revenue for the government. The tobacco is the biggest revenue for the government. This has been started about 10 years back. Tobacco has to be banned. But what are the people who are growing tobacco? How much is the this one for them income? And for the government revenue, how much of the revenue government gets? Like alcohol, why alcohol has not been banned? We know that. And you know how once the COVID first wave, after that, when they opened the shops, alcohol shops, how it was? We have literally seen people queues, length and length of the queue, miles and miles of the queues you have seen for the alcohol. How can you ban it? Do you think that the people will agree? No, it is. So instead, what we have to do that so much of awareness we have to create that the people should stop using that. Youngsters especially should stop using that. Automatically, then the production will come down. And then government also will accept that. Economy is that, the demand and the supply.
Definitely. On the other side are also tobacco farmers who can get very negatively impacted. So it has to start as a phase by phase. It cannot be a ban. You need to relocate them. You need to get them a newer occupation, and only then. So it's a multi-pronged therapy.
Yes, it is not that easy what we say that. It cannot be done. But we have to do whatever we can do. We teach our children not to use tobacco. That's the first thing what we need to do in our houses is our husbands, our uncles, and then children, brothers. We must say sisters. Now the girls are smoking. Now we have to tell them that please don't go to the tobacco. You spoil your life. That's much we can do.
Dr. Amita Singh, you could unmute yourself and tell us about it. I think you're talking about the treatment facility. Is that what you're talking about? Yes, ma'am. But the questions are there. So that's okay.
More time for me to talk?
No, that's totally okay, ma'am. That's totally okay. Dr. Amita, would you want to talk about it? You want to unmute yourself? You mentioned it's ABAC. Do you want to talk about it? Okay. I think, thank you, ma'am. That was,
okay.
Don't worry, ma'am. Ma'am, don't worry. Don't worry.
Okay. Thanks a
It
lot.
was really,
again.
really wonderful. As Dr. Lakshmi mentioned, right? The passion is so visible and it's so, motivational for all of us to fight cancer or help fight cancer and get awareness, create awareness in people to fight cancer, ma'am. It was a real pleasure.
Okay, thanks a lot again for giving me this opportunity. I enjoy giving a little awareness. If it is useful to somebody, I call it a day for me. And for giving me this opportunity, I thank you, Geeta, Lakshmi, and the whole team of Mira.
Thank you so much, ma'am.
Thanks a lot.
Thank you very much, Doctor. It was a very enlightening talk, no doubt about it.
Thanks
I think the accent was only on ladies getting this treatment, getting that, HPV vaccine, this, that. And what about the men folk? I mean, are we going to do anything about their sexual activities?
Very good
Are we
question.
going to, see that?
Very good question. In all other countries, boys have been vaccinated with HPV vaccine. Here also in India, few people, because in India, unfortunately, the government has not yet approved. That's why only the state governments have to take it up and give the vaccine. Only 3 states have been giving the vaccine, that is Sikkim, Punjab, and Delhi for some time. Now I think Tamil Nadu is taking it up. Karnataka, I'm fighting with the government to take it up and do. The boys have been, really right question you have asked. Boys also have been given, and it is advocated, it is recommended for boys also. The same age, boys below 15 to 16 years of age, the boys are also has been given the vaccine in all other countries. That's why Australia so boldly says it eradicates by next 2 years, because it has vaccinated both boys and girls. Once you vaccinate both boys and girls, probably it is very, very less chance to have the cervical cancer. It can be done.
Thank you, ma'am. Thank you.
Have to do any
Moving on.
with the government, because I think this is such a necessity. It has become now,
It is.
especially with the use of condoms. I see, in fact, a lot of youngsters, when I really visit the medical stores, they all are buying condoms and they think that it's preventing, I think.
Yeah,
that's
please.
also
One thing is condom will not prevent HPV transfer.
Yeah.
Even just a skin to skin touch itself is enough. The condoms, though, for all other sexually transmitted diseases, including HIV, condom is very effective, but not for HPV virus transmission. So people have to remember that.
Thank you, ma'am. Thank you. Moving on, we will have a short video. Thank you so much, Sundari ma'am, for joining us.
Thanks a lot. Thanks a lot.
Moving on, we will have a short video presentation by Dr. Niti Raizada, who is currently the Director, Department of Oncology at Fortis Hospitals, Bengaluru. Due to unavoidable circumstances, she could not join us in person today, but has graciously permitted us to use her short video clips regarding genetic testing for cancer. Dr. Tanvi, it would be great if you could play that for us. Dr. Tanvi, the audio is not...
So you can go to more on top and share video, share some.
Have a treatment which would be one type for one cancer. What would it cause? Well, some patients would have extremely good response, but there would be some patients who may not have favorable response, and some patients who might actually have more aggressive disease or progression. And what we have reached now in 2022 is an era of precision oncology and precision medicine. How and where? Well, there is immense data known as bioinformatics, and it is combined together into a format which is known as multiomics. So we have genomic data, we have environmental factors or epigenomic data, we have data from microbiomes, transcriptomes, and metabolomics, proteomics. All this data has to be used in a useful way for the patient, thus causing precision oncology or precision medicine. What is the most important tool when we are doing this? Well, the one tool is next generation sequencing, which analyzes the tumor in such a way that we find out what are the important pathways which can be used to target a particular cancer. And these important pathways which we commonly use now are RAS-RAF pathway in colon cancer. We use EGFR-ALK-ROS pathway in lung cancer, and there are many of such pathways. But this actually leads to something known as a comprehensive genomic profiling or comprehensive molecular profiling. And what in reality it does is that we find out driver mutations which are the mutations which actually drive the cancer, or it could be bystander or passenger mutations, which sits besides but we cannot target them. There are certain undruggable mutations. So we have a mutation, but we don't have a drug which can target it at this point in time, which may change in the next several years. And then we find out certain pan-tumor markers. These pan-tumor markers can be tumor mutation burden or microsatellite instability. And these are markers to decide whether we can give immunotherapy. When we also have CGP data, we find out whether we can give safe drugs with less side effect, which improves the quality of life of patient. So in summation, we have focused care, customized care for minimal side effects and for maximum output. These are useful for our current battle against cancer.
So how is CGP or comprehensive genomic profiling used in oncology clinics? Well, gone are the days when oncologists would actually treat patients with the same kind of treatment approach to one cancer. With generic treatment, what would happen? Well, some patients would definitely have favorable response, but there will be some patients who would actually have no response at all, and some tumors which would have more clinically aggressive behavior. With more and more cancer-related research, we have realized that cancer is a multiple genomic event with multiple genetic alterations. Quite a few of these genomic processes are standardized now, and we commonly use it in our clinical practice, including RAS-RAF pathway in colon cancer. We commonly use EGFR AL-cross in lung cancer, but we need to consolidate more and more emerging information so that we can customize treatment or personalize treatment. Now, in reality, what we know is that we are entering a world of immense information, bioinformatics, and there's unlimited data available, which includes data on genomics, data on epigenetics, well, data on microbiomes, transcriptomics, metabolomics, proteomics, and so on and so forth. So there's technically a world of multiomics. And this is going to be the next era or next generation of oncology. At this juncture, we need precision oncology and personalized oncology. And with this in mind, we have next-gen sequencing, that is next-generation sequencing. And this has become an indispensable tool in our routine clinical practice. And what it does is assess certain biomarkers with a very small amount of tissue and, of course, a very less time also. And here comes the concept of comprehensive genomic profiling. This is known as CGP or CMP, which also means comprehensive molecular profiling. So how does CGP change our clinical practice? Well, importantly, we realize that there are driver mutations or cancer-specific mutations which drive the tumor, which react or which actually can be treated with targeted drugs, or the entire mutational landscape of one cancer. We also find out bystander mutations or passenger mutations, which are probably not the main targets of cancer. Along with this, we identify actionable mutation versus undruggable mutations. Importantly, now we find out the pathways of resistance so that we can again direct specific treatment. We find out certain genomic signatures like tumor mutation burdens, that is TMBs, and MSI, that is microsatellite instability. These by and large are known as pan-tumor markers and are targets for immunotherapy. We also have learned that CGP-informed targeted therapies and immunotherapies have by and large very less toxicity and have certainly worked a long way in improving quality of life of our patients. We have to adopt these changes in our routine clinical practice for optimizing clinical care. Well, the CGP-derived insights have been indispensable tool in the battle of cancer, and in coming age, we'll have more and more data of this, more and more genomic-derived data, which we can comprehensively use for our oncology patient. With the help of more important application of precision oncology and precision medicine. Thanks so much.
Thank you, ma'am. If we have no more questions, do we have any questions? Okay. So like every year we have a theme, we have a theme this year too for World Cancer Day. The theme this year is Close the Care Gap. We at Niramai believe that the first step to closing the gap is to create awareness about cancer. And I'm so glad that we're in the right direction. For that, I would like to thank our speakers of the day coming together to address the one major disease burden of cancer. As Dr. Ramachandra sir rightly said, the number of cancers are only increasing every year, especially in younger population. And the major culprit is our lifestyle, fatty diet, lack of exercise, and stress. And it is only upon us to fight these culprits by maintaining a healthy lifestyle, caring for both physical and mental health. We should, of course, pay attention to the breast in the right way. And as mentioned by Dr. Somashekhar sir, do not panic if there is a lump, but get yourself checked every year, even if you do not have a family history of breast cancer. Be wary of the risk factors for breast cancer and get yourself screened regularly. Dr. Vishal Rao mentioned about prevention, how that is the greatest modality to fight oral cancer, especially. Apart from bringing in positive lifestyle changes, it is very, very critical that we quit tobacco and encourage others to quit tobacco, as this is one cancer which we largely bring upon ourselves. We ourselves are responsible for oral cancer. Dr. Sundari Sturk highlighted that while cervical cancer was the most common cancer a decade ago, and now it is the third most common cancer in India, we still have over 1 lakh new cases diagnosed every year, and we cannot let down our guard. We will have to ensure that we get ourselves and the women we know screened for cervical cancer. And if we have, young kids, nephews, nieces, encourage them to get the vaccination. A very special thanks to Ms. Megha, who has shown us that this disease can be conquered and how. Thank you for being a part in our efforts to increase awareness of this disease and for sharing your journey with us. It definitely reduces the taboo around this disease and opens up avenues for more such conversations. Well, I don't see any questions. So if I can take this opportunity that Geeta and I may have been the face that you're frequently seeing during this webinar, but it's also the work of my teammates that I'm showcasing. Thank you, Dr. Tanveen, for making this look so easy and effortless. I know it wasn't. Thank you, Ankita, for creating the posters, flyers, and videos. I also thank Geeta, Siddharaju, Dr. Gagi, Tanmay, and all my colleagues in Niramai for pitching in to do all the background work. Finally, I thank you, audience, for staying back. It was a long webinar, I understand, but it is for you that this webinar is meant to be. You encourage us to bring out the best in us, and we would be even more thankful. I'm stressing this more and more, but we would be even more thankful if you went out today and got yourself screened for the common cancers and convince your family and friends to do it as well. If you could get screening and convince 5 more people to get screening, I think we can all work towards reducing the cancer burden. And while the challenges that we as a system face are multifaceted, we at Niramai aspire to make cancer screening available and accessible to both the urban and rural communities, and thus close the care gap. Thank you.
Thank you very much, everyone, for joining. And I echo what Dr. Lakshmi mentioned. And just one more point, this same video is available on our YouTube channel, and please share, because it's something that people can watch whenever they have time, and it's something not just watchable on Cancer Day or World Cancer Day. Whenever you have a doubt, you can come in and refer to the notes. Thank you so much for staying on.
Thank you.
We end the